The Subcommittee on Oversight and Investigations hearing will now come to order. Today, the Subcommittee on Oversight and Investigations is holding a hearing entitled Lessons from the Frontline COVID-19's Impact on American Healthcare. Today's hearing will examine the COVID-19 pandemic's impacts and how providers, the healthcare system, and patients can better prepare for future variants and future public health emergencies. Due to the COVID-19 public health emergency, members can participate in today's hearing either in person or remotely via online video conferencing. In accordance with the updated guidance issued by the attending physician, members, staff, and members of the press present in the hearing room are not required to wear a mask. For members participating remotely, your microphones will be set on mute for the purpose of eliminating inadvertent background noise. Members participating remotely will need to unmute your microphone each time you wish to speak. Please note that once you unmute your microphone, anything that's said in Webex will be heard over the loudspeakers in the committee room and subject to be heard by the live stream and C-SPAN. Because members are participating from different locations at today's hearing, all recognition of members, such as for questions, will be in order of subcommittee seniority. If at any time during the hearing I'm unable to chair the hearing, the vice chair of the subcommittee, Mr. Peters, will serve as chair until I'm able to return. Documents for the record can be sent to Austin Flack at the email address we provided to staff. All documents will be entered into the record at the conclusion of the hearing, and the chair will now recognize herself for purposes of an opening statement. Over the past 2 years, this subcommittee has held 8 hearings examining the COVID-19 response, covering everything from vaccine development and deployment to the impacts of the pandemic on children. Today, this subcommittee continues the examination, building on its long history of pandemic preparedness oversight. We'll hear from the on-the-ground providers about how the pandemic has impacted their own lives, the healthcare systems they work in, and the patients that they serve. Their frontline perspectives will provide insight into how we can better protect the health and safety of our communities throughout the remainder of this pandemic and help us better prepare for future public health emergencies. While our witnesses today represent an array of experiences, there are many other types of healthcare providers serving a range of communities that have felt similar impacts from this pandemic: emergency medical technicians, nursing home and in-home healthcare providers, and physical and occupational therapists, to name a few. As we all know, the COVID-19 pandemic has impacted nearly every aspect of American life. The healthcare system is no exception, which has faced these impacts head-on. Resource constraints and workforce shortages existed long before the pandemic started, but have been exacerbated to alarming degrees over the last 2 years. A recent poll found that nearly 1 in 5 healthcare workers quit their jobs during the pandemic, and nearly 1/3 of those remaining have seriously considered finding new jobs. And we've heard the reasons for some of this from the mental health experts who testified before the subcommittee 2 weeks ago. I've heard similar experiences during a recent visit with some of Colorado's healthcare workers. And I know many of you can attest that the feelings of burnout, exhaustion, and unmanageable stress are echoed in hospitals and healthcare settings throughout the country. We must find a way to ensure these critical workers have the support they need. Of course, the cascading impacts of COVID-19 do not stop with the workforce alone. The COVID-19 surges due to new variant waves have led to significant capacity constraints within hospitals. And when hospitals are overwhelmed, patient care can suffer. Heart attacks, car accidents, and other emergencies don't stop for COVID-19. Routine preventative care and so-called elective procedures, often involving life-saving treatment, have been delayed due to surges in the pandemic. But the end of a COVID-19 surge does not necessarily bring the relief we hope for, as patients seeking backlogged services flood facilities. Moreover, the combination of workforce strains and capacity challenges further compound historical inequities and health disparities, presenting further barriers to care for people of color and other underserved communities. There's no single solution to these challenges, but we do have the tools to help alleviate some of these concerns today. The most effective way to fight the pandemic and lessen the burden on our healthcare system is for eligible Americans who have not gotten the COVID-19 vaccine to get vaccinated. CDC data shows that unvaccinated adults are 16 times more likely to be hospitalized and 14 times more likely to die from COVID-19 than fully vaccinated adults. Further, unvaccinated adults are an astounding 41 times more likely to die from COVID-19 than those who have been fully vaccinated and boosted. The science is clear. Vaccines are safe and effective, and they're our best shot, literally, at alleviating the impacts of future surges of COVID-19 on our healthcare system. But vaccines alone will not help us prepare for future public health emergencies. We must identify what steps we can take now to rebuild and strengthen the healthcare workforce so the burnout, trauma, and resulting impacts on patient care can be avoided. And critically, we must ensure that future public health emergencies do not inflame existing disparities in access to care and health outcomes for vulnerable populations and marginalized communities. Congress and the Biden administration have begun to address some of these concerns through investments in prevention measures and healthcare workforce and system support, but more must be done. As a nation, we've relied on healthcare workers to bear a significant burden these last 2 years, working long hours and extra shifts, often at great risk to their own health and that of their families. We owe a debt of gratitude for their leadership and their sacrifices. I look forward to hearing all of their insights and recommendations for how we can work to keep America safe and healthy for the remainder of this pandemic and for the future. And I'm now very pleased to recognize the ranking member, Mr. Griffith, for 5 minutes for an opening statement.
Thank you, Madam Chair, and appreciate you holding this hearing. Understanding the lessons learned from COVID-19 pandemic is crucial for future decision-making. Americans need to learn to live with COVID-19, and the federal government needs to learn to better prepare for and handle future pandemics. It is our duty on this subcommittee to oversee the federal government's COVID-19 response, to examine what worked and what did not. I have heard from frontline workers in my district about both successes and failures experienced over the course of the last 2 years. One of the best things to come out of this pandemic for rural areas like my district is increased use of telehealth. Thanks to flexibilities from the Centers for Medicaid and Medicare Services and others, residents who were shuttered into isolation could connect to their doctors and nurses virtually. From mental health appointments to cardiology checkups, doctors and patients alike were appreciative for the ability to use at-home equipment to monitor and to test. Other emergency flexibilities implemented by federal and state governments also helped increase patient access to health care, such as allowing pharmacists to deliver vaccines and allowing hospitals to compound medications that were in short supply. As we move forward, this committee should examine which of these flexibilities should be available on a permanent basis. During COVID-19 surges, many hospitals across the country had to think fast, often surprising even themselves with creative solutions. Ballot Health, a healthcare system that serves much of Southwest Virginia, created a Safe at Home program. This program helped healthcare workers monitor COVID-19 patients at home by providing kits with a thermometer and a pulse oximeter. Nurses called patients to help monitor them from home and help schedule follow-up appointments for further care when necessary. Based on patients' self-monitoring, the Ballot Health system cared for thousands of patients this way. By screening patients at home and preserving precious resources in the hospital for the sickest of patients, this program reduced hospital admittance rates, keeping beds open for those who needed them most. Despite these successes, certain policies and mandates implemented throughout the course of the pandemic resulted in setbacks in my district. The decision to delay elective procedures eventually backfired for some patients in hospitals. The delay of treatment and preventative screenings resulted in worsened conditions for patients. People often think of elective surgeries referring to something cosmetic or optional. However, the term is broad, covering many critical procedures, including cancer screenings, hip replacements, hernia repairs, or the removal of kidney stones or an appendix. We saw a temporary fix to manage staff shortages, and the influx of COVID-19 cases ultimately leave patients frustrated, nervous, and in weakened health. And in some cases, like that of our friend Congressman Andy Barr's wife, the delay in care became fatal. Other challenges to our nation's healthcare systems were a result of overburdensome federal mandates. Vaccine mandates made people choose between personal choice or their livelihood, which we know made existing problems in recruiting and retaining healthcare workers in rural areas worse. Amid federal COVID-19 vaccination mandates for healthcare facilities, healthcare workers have been fired for noncompliance, and some have resigned or quit. In a rural hospital, the loss of staff is not only noticeable, but very damaging. Any loss of staff is detrimental to rural hospitals. Through this pandemic, our nation's healthcare workforce has learned that it is possible to be resilient in a crisis. Even the smallest changes to care can have the biggest impact on patient health, staffing, and hospitalization rates. This is especially true in rural districts with smaller staffs, where each person plays an important role in keeping the hospitals running. The mandate didn't work. Now, that being said, I agree with Chairwoman DeGette. I've been vaccinated. I think it's an effective tool. But making it a mandate has forced people to choose whether they continue to work in our local hospitals or in healthcare systems or give up their jobs. It is critical that we take a closer look at the experiences of frontline workers and examine lessons learned as we discuss solutions to face the next pandemic. I look forward to hearing from our witnesses what they experienced on the front lines and what we can do to incorporate their lessons that they learned as we prepare for the next pandemic. Thank you very much, Madam Chair, and I yield back.
Chair now recognizes the chairman of the full committee, Mr. Palone, for 5 minutes.
Thank you, Chairwoman DeGette. Today, the committee will continue our oversight of the ongoing COVID-19 response by hearing from frontline healthcare workers who have served their communities throughout the pandemic. Their experiences offer valuable insights into our current response and ways we can better be prepared for future public health emergencies. And nearly 4.5 million Americans have been hospitalized due to COVID-19, and more than 930,000 Americans have lost their lives. No one has been unaffected by the pandemic, though seniors have been particularly vulnerable to the disease, and communities of color have faced disproportionate impacts. Essential workers and frontline responders, such as the healthcare workers joining us today, have faced additional risks and burdens. Over the last 2 months, the Omicron variant ripped through our communities, spreading quicker than prior variants. While Omicron appears to have peaked, the experience has shown that we must remain vigilant as new variants emerge, and we have to continue to use the tools available to us to prevent transmission of COVID-19 and protect the most vulnerable among us. Now, evidence shows that being fully vaccinated and boosted is the most effective way to fight COVID-19 and its impacts on our community. This remained true even during the spread of Omicron variant, where unvaccinated Americans continue to face a greater risk of severe disease and death than those fully vaccinated. Yet today in the United States, only 69% of eligible Americans are fully vaccinated, and just 45% have gotten a booster dose. So I look forward to hearing from our witnesses about the efforts they found successful in encouraging people to get the vaccine and the booster dose. Because unfortunately, despite all the available tools, the pandemic continues to substantially strain our nation's healthcare system. The pandemic is exacerbating long-standing workforce shortages, capacity issues, and barriers to access for people of color and other underserved communities. As COVID-19 surges caused patients to overwhelm hospitals and medical facilities, healthcare workers have faced both mental and physical challenges. They're experiencing work overload, burnout, and increased anxiety or depression, with women, Black, and Hispanic healthcare workers reporting higher stress. And as different variants have emerged, hospital capacity has at times surpassed the number of staff beds available. So this week, more than 75% of ICU beds in hospitals across the United States remain occupied, despite the fact that the Omicron wave has crested. And this strain not only adds to healthcare workers' burden, but can affect patient care and potentially their health. Capacity constraints, fear of contracting COVID-19, and other barriers to healthcare led to 4 in 10 adults delaying or avoiding medical care in the early days of the pandemic. 1 in 8 adults, and an even higher rate for Black and Hispanic adults, postponed emergency care. And delayed preventative care and diagnosis can lead to chronic life-threatening illnesses. As the pandemic continues, we must contend with these broader and longer-term impacts on Americans' health. Fortunately, Congress and the Biden administration have taken action to support America's healthcare workforce and protect the health and safety of all Americans. The American Rescue Plan and the CARES Act provided billions of dollars in funding to address worker retention and wellness and resources for healthcare providers serving children, low-income individuals, and seniors. And then last November, this committee passed legislation that would provide support to the healthcare workforce and expand access to important preventative services. The House-passed Build Back Better Act also included key provisions to invest in public health infrastructure and the healthcare workforce. The Biden administration has also made hundreds of millions of tests and masks and COVID-19 vaccines and therapies available to Americans at no cost. The president talked even more about what he plans to do in the future last night. And these are critical steps to supporting the nation's healthcare system and the public's health, but more must be done to ease the burden on healthcare workers and bolster capacity. So I just wanted to say, Madam Chair, I'm grateful for the tireless commitment our nation's healthcare workers have shown for the last 2 years, and look forward to hearing from our witnesses about their experiences on the front lines. Together, we can strengthen America's continued response to the COVID-19 crisis. If I could just say, Chairwoman Dingell, I know that many times you've approached me and talked about how we have to be better prepared. And I know that even before the pandemic, when it started a couple years ago, you were talking to me about, long-term preparedness for viruses and other healthcare emergencies. And I appreciate the fact that you and the members of the committee in general, want us to think about the future. Right now, everybody's saying, oh, everything's great, right? It's not. We still have a lot of problems. But more important, and this is what you've always stressed, Diana, we have to think about, the next pandemic or the next wave. And this is a very important part of this committee's function. So thank you.
I thank the chair. Chair now recognizes the ranking member of the full committee, Mrs. Rogers, for 5 minutes.
Thank you, Chair Dingell, Republican Leader Griffith. We owe it to today's witnesses and all our frontline heroes to listen to them, to understand their perspectives, and to provide solutions. The families who lost loved ones, about 947,000 in the United States, and those who've suffered and sacrificed during the pandemic are owed answers to many questions. First question, how did the pandemic start? Republicans on this committee have been leading a comprehensive investigation into the COVID-19 origins, and we continue to urge our colleagues on the other side of the aisle to join us in this pursuit. Understanding how this pandemic started is one of the most important public health questions of our time, and it is necessary to answer, hopefully, to prevent future pandemics. Second, why weren't we better prepared? The federal government could have provided more resources to healthcare responders. For years, the Republicans on this committee have raised concerns about the wisdom of not funding frontline healthcare preparedness instead of spending more than $80 million a year on the BioWatch program that started in 2004. In a report to the bipartisan leadership on this committee, the GAO found this program doesn't have the science to show that it even works. We've also raised concerns about relying on China and other foreign countries for critical medical supplies, which we all know we must address. Third question, why is CDC mixing politics with science? Lockdowns, distancing, and masking were almost exclusively emphasized by the CDC, while concerns about the effects on mental health and social and economic costs have been ignored. Fortunately, the Trump administration led public-private efforts to expedite the development of effective vaccines and therapeutics. The vaccines vastly reduced the risk of death and hospitalization, and now we have data on what many of us have known from the beginning. Natural immunity provides robust protection. But even with the effective vaccines and better understanding of who is most at risk, the Biden administration has continued an unbalanced response, uninformed by these advances. There is far too much fear and far too much confusion. The CDC led from behind on the issue of school closures. Several countries in Europe never closed their schools. Some localities in the US and even CDC Director Walensky herself, before she came to CDC, saw no difference in safety between 3 feet and the CDC recommended 6 feet distancing that was keeping schools closed. Yet when her agency put out the school guidance, she required 6 feet of distance. Why? Because she gave the teachers union a policy pin. As a direct result of CDC's guidelines, children have paid a significant price in mental health harms, lagging education, and lost time for social development. Even when schools were mostly reopened, CDC continued to force masking requirements, even for young children, in a departure from World Health Organization and UNICEF recommendations. And the CDC continues to rely on discredited studies to force their masking agenda on kids. The CDC suppressed a large study it funded that showed little benefit to masking in schools. It cherry-picked data by highlighting a discredited study and suppressing another one. But there's more. The CDC also collected data on vaccine and booster effectiveness, breakthrough infections, and wastewater analysis, but released very little of it. The CDC deprived hospitals and frontline workers of data that would have better informed mitigation and treatment efforts. All of these moves of the CDC have undermined trust in public health when it's needed most. The fourth question: why did the Biden administration take actions that made it harder on frontline healthcare workers? Many hospitals struggled with staffing shortages, but vaccine mandates may have further worsened the staffing situation at hospitals. During the height of the Omicron surge, the Biden administration took nearly $7 billion from the Provider Relief Fund, meant to help hospitals and clinics affected by the pandemic, and used it to buy COVID-19 vaccines and therapeutics. Congress had set aside that money to help providers pay for pandemic-related expenses, including staffing, personal protective equipment, care for the uninsured, and vaccine distribution. This relief was badly needed by rural hospitals that were competing to hire temporary contract staff. These are just a few of the questions that this committee needs to pursue. We must get answers to ensure the frontline heroes, like all of you, have trust and confidence in public health. Thank you, Madam Chair. I yield back.
Thank the gentlelady. I now ask unanimous consent that members' written opening statements be made part of the record, and without objection so ordered. I would now like to introduce our witnesses for today's hearing. Dr. Megan Ranney, an emergency physician at Rhode Island Hospital; Tawanda Austin, Chief Nursing Officer at Emory University Hospital, Midtown; Dr. Daniel Caddlek, Chief Medical Officer for the Indian Health Council, Inc.; Dr. Laura E. Riley, obstetrician and gynecologist-in-chief at New York Presbyterian Hospital, all appearing on Webex. And then in person, we have Dr. Lucy McBride, a private practice internist. I want to thank all of the witnesses for appearing before the subcommittee today. I know all of you are aware that the committee is holding an investigative hearing, and when we do so, we have the practice of taking testimony under oath. Does anyone have an objection to testifying under oath? Let the record reflect the witnesses have responded no. The chair then advises you, under the rules of the House and the rules of the committee, you're entitled to be accompanied by counsel. Does any of you wish to be accompanied by counsel? Let the record reflect the witnesses have responded no. And so would our witness in the room please rise, and everybody else, please raise your hand so you may be sworn in. Do you swear that the testimony you give is the truth, the whole truth, and nothing but the truth? Thank you. You may be seated. And let the record reflect that the witnesses have responded affirmatively, and you're now under oath and subject to the penalties set forth in Title 18, Section 1001 of the United States Code. Now, at this time, the chair will recognize each witness for 5 minutes to provide their opening statement. Before we begin, I'd like to explain the lighting system for the witness testifying in person. That would be you, Dr. McBride. In front of you is a series of lights. The light will initially be green. The light will turn yellow when you have 1 minute remaining, and so start to wrap up at that point. The light will turn red when the time expires. Now, for the witnesses who are testifying remotely, there's a timer on the screen that counts down to the remaining time. And so, first of all, I would like to introduce Dr. Ranney for 5 minutes. Doctor?
Thank you so much. I appreciate the invitation to testify, Chair Pallone, Ranking Member Rogers, Madam Chair, and members of the committee. Monday marked 3 years since our first COVID case in Rhode Island. I was working in the emergency department that night, and I have continued to work on the front lines of COVID-19 response throughout the pandemic. I therefore testify today as a practicing board-certified emergency physician, public health researcher, academic dean of the School of Public Health at Brown University, and mother of 2 school-aged children. Let me start by recognizing that in so many ways, we are in a better place than we were 2 months ago, much less 2 years ago. We've had quick development and rollout of vaccines, therapeutics, and use of masking, testing, ventilation during surges. Omicron cases are plummeting. But despite this progress, the situation in healthcare facilities has deteriorated to new lows. Only a few weeks ago, a nurse in charge of my emergency department told me she was 10 nurses short for the evening and therefore forced to reduce services. She said, "I've been begging people to stay all day long, offering double time and double incentives, but the nursing staff is too burnt out." So today I will highlight 4 challenges ahead and then propose ways to leverage this fleeting window of opportunity we have to protect the health of America. I also respectfully ask the members to read my written testimony, which contains many firsthand accounts of the challenges we face. Let me start by discussing the profound impact of COVID on accelerating staff shortages and hospital overcrowding, particularly in emergency departments, the only place in our system that provides care to all 24/7, 365. Some have reported that as many as 1 in 5 healthcare workers, not just docs and nurses, but home health aides, EMTs, social workers, and more, have left bedside care during the pandemic. These staff shortages are a problem across the nation, although rural communities are disproportionately hurt. During COVID surges, due to these shortages, many hospitals have had to resort to extreme measures, calling in the National Guard, shutting down so-called elective procedures, to try to save space for true emergencies like strokes and traumas. But even with these steps, we have been unable to care for patients in a timely manner. One nurse recently told me that every day in the ER feels like she's going before the firing squad due to her inability to provide adequate care. Surgeons have shared their anguish at watching patients lose vital functions due to delays, which highlights the most significant reason for the staffing shortages: the mental and emotional effect of repeated COVID-19 surges on our healthcare providers. We keep showing up, but our work keeps getting tougher, and there are no reinforcements in sight. In my own specialty, the proportion of emergency physicians experiencing burnout has increased from 43% to 60% during the pandemic. We also report increasing moral injury, depression, PTSD, and workplace violence. We must fix these core issues to save healthcare. Second, COVID has exposed weaknesses in our healthcare data and information systems. We need good data, timely, accurate, transparent, and complete to make good decisions about what's needed, where, when, and for whom. Thanks to the CARES Act and ARP, the CDC and HHS temporarily have access to many important data streams, making earlier citizen-led data efforts unnecessary. But important pieces of data are still missing, things like actual numbers of staff beds in hospitals. Lack of data related to race and ethnicity are particularly glaring. And it is unclear what will happen to even these preliminary data sources once the public health emergency is over. I and others deeply fear the loss of hard-won data gains. Third, we have continued problems with the healthcare system's supply chain. Although early PPE shortages have resolved, we face new and worsening problems with key tests, therapeutics, and equipment for both COVID and non-COVID related care. The life-saving work of folks like myself is heavily affected by these swings in supply. We're forced to substitute one preferred medication or treatment for another, and sometimes there is no substitute. This directly hurts patients. Finally, the increasing politicization, misinformation, and public mistrust around COVID has had a deep impact on healthcare workers, public health, and the quality of care provided. 3/4 of healthcare workers say that misinformation has negatively influenced both patients' decisions to get vaccinated and patient care. But all of this can be fixed. As Americans, we have a long history of transforming public health crisis into opportunity. In my written testimony, I provide specific examples, some were highlighted by President Biden last night, including systemic fixes to the healthcare delivery system, support for healthcare workers, investing in training and retaining all types of healthcare workers, treating the medical supply chain not as any other part of the US economy, but rather as a concern of national security and health, and finally, rebuilding trust. In close, every American wants to be able to show up in an emergency department and get timely, appropriate care for their emergency. Right now, they can't. Throughout the pandemic, we have relied too heavily on stopgap solutions instead of addressing the underlying issues. I urge you, please think bigger and do more. Thank you for your time.
Thank you so much, Doctor. I'm now pleased to recognize Ms. Austin for 5 minutes.
Good morning, Subcommittee Chairwoman Diana DeGette, Subcommittee Ranking Member Morgan Griffith, members of the committee, and my fellow witnesses. Thank you for inviting me to participate in today's hearing. The views that I express today are my own views and do not necessarily reflect the views of my employer. My name is Tawanda Austin, and I serve as the Chief Nursing Officer and Vice President of Patient Care Services at Emory University Hospital, Midtown. I've been a nurse for over 20 years, and the COVID-19 pandemic presented the biggest challenge to the healthcare workforce in decades. Today, I'm going to talk about the multi-year mental and physical strain on nurses, hospital capacity challenges, and the worsening workforce shortage that Congress must address. I recall rounding in our COVID ICU at the end of 2020, and I will never forget the exhaustion and despair that I saw on the nurses' faces. This is an ICU team that are innovators and they're highly engaged, a team that proudly received a third Beacon Award during the pandemic, so it was not customary to see them look so defeated. As I walked around getting a pulse check on the nurses, one nurse said to me, "Walk with me, I want to show you something." She took me to 4 patients' rooms. We stood on the outside of each of those rooms, peering through the glass windows, as she explained to me how severely ill each of those patients were, and she outlined the numerous medications and complex therapies they each were receiving. She paused and said, in her best clinical estimation, that not a single one of those patients would survive. I believe her mission was purposeful. She wanted me to experience for just those few minutes what it was like to be on the front line, how devastating it was to do everything possible to save a patient's life, only to lose them in the end. I remember feeling deflated because as a leader, it's my duty to support, to help find solutions to problems, to offer comfort when it's needed, but I didn't feel that that was enough in that moment. As I continued to make rounds in the ICU, I stopped to check on another nurse who appeared to be the most exhausted of all the nurses that I'd encountered that day, and I asked how she was doing. She explained to me that she was caring for 2 patients that day, although one really required intensive one-to-one care. She was extremely overwhelmed and stretched too thin. She had spent most of her day in this one patient's room and had not been able to check in on the other patient as often as she wanted. On this day, like many others, the unit was short-staffed, but fortunately the nurse in charge was able to support her with the care of her second patient. These are just a few of the all-too-common stories that have emerged from hospitals during the COVID-19 pandemic. I share these stories with you today because they illustrate the incredible pressure on our staff who've been caring for COVID patients for nearly 750 days. In addition to the physical strain, there's the mental stress that's plaguing our workforce. The morale of nurses has declined over time as they continue to care for patients who are extremely ill and who are suffering and dying. Additionally, nurses have shared stories of being verbally attacked for implementing COVID-19 safety restrictions. Patients' families have become frustrated and distressed, taking their emotions out on nurses, and workplace violence is at an all-time high. The COVID-19 pandemic has tested the capacity of all hospitals. We are facing extremely long wait times in our emergency department, and at the beginning of COVID, Emory paused our elective procedures, and providers were redistributed to our COVID units to support testing and to support our vaccine clinics. But now that we're back at regular operations, we again feel the immense shortage of nurses. Early in the pandemic, we saw nurses leave. Now we're experiencing additional staffing issues as support staff have also fled the industry, adding to the nurses' daily burden. While we face challenges, Emory nurses have stepped up. The COVID-19 pandemic forced our nurses to find new and innovative solutions to the challenges brought on by this public health crisis. Emory nurses placed baby monitors in the COVID rooms, and this allowed them an additional way to communicate with patients quickly and make patients feel less isolated. It also saved on PPE by consolidating the nurses' visits into the room. So instead of donning PPE to go in and hear the patient's request, the nurses received the request over the baby monitor and entered the room once to deliver the needed care. As we emerge from this pandemic, various lessons can be learned from the experiences of healthcare professionals. First, we need a far more robust workforce to combat burnout and overall shortage of providers. I urge Congress to fund pathways for more young people to enter the nursing field and programs to retain our staff. Second, we need to address issues surrounding travel nursing agencies. While these businesses offer the chance for hospitals to bolster their workforce during surges, their costs have risen to unsustainable levels. urge Congress to take action so that hospitals remain financially viable and avoid the risk of having to reduce services, or even worse, avoid the risk of shutting their doors. Finally, I urge Congress to take a deeper look into the rising trend of violence towards healthcare workers and find steps to mitigate this trend. I look forward to your questions. Thank you.
Thank you so much. Dr. Caddlek, now I recognize you for 5 minutes.
Good day to Chairwoman DeGette, Chair Congressman Pallone, Congressman Rogers, and Republican Leader Griffith. Thank you so much. My thanks to all the healthcare workers' hard work over the last 2 years. The testimony provided today is not necessarily reflective of my corporation. I'd like to provide a brief description of the effect and response to COVID during the period of March 2022, January. So the context of this response is based in the Southern California area. My primary role at the facility is Chief Medical Officer at this facility for the past 19 years. I serve as the primary care provider for the panel of patients that services 9 American Indian tribes in these areas. We currently operate out of a 50,000 square foot facility that is located approximately 40 miles northeast of San Diego. There's an additional 12,000 square foot facility about 25 additional miles from the main site in the mountainous areas. We provide a multidisciplinary ambulatory care facility that provides care to approximately 20,000 American Indian clients in the surrounding area. However, about 5,000 of those are active patients. The organization provides multiple disciplines, including internal medicine, family practice, pediatrics, general dentistry, behavioral health, public health outreach. We also provide additional subspecialties, including orthodontics, endodontics, orthopedics, acupuncture, optometry, OB-GYN, substance use disorder management, marriage family therapy, pharmacy services, and podiatry. The organization also contracts with outside agencies that are in neighboring cities 20 or 30 miles away. I provide care as a primary care physician, as I mentioned, internal medicine. I'm also a pediatrician trained, and also provide hospice care services to our community. So our COVID response in that time is spread over the northern half of San Diego County. And so just for references, the area covers about 10,000 square miles. Of note, the Southern California area is home to over 30 different tribal entities with different cultures, different dialects, and hence the need to be culturally appropriate in these types of primary care delivery. One can obviously see the issues regarding delivering COVID-sensitive response care to these communities. In this setting, a epidemic has not been seen to this magnitude since the early 1900s. In a community where the average lifespan is 10 to 15 years less than the average American, the tribes in the surrounding area were required to mount a response that was replete with challenges, including dealing with the geographic diversity, the economic issues that have been persistent over the past 100 years. Considering the limited resources from which to work, the tribes provided boots on the ground workforce by spreading information by word of mouth, flyers, social media when appropriate. It's important to acknowledge that in the area that I work, only half of the tribes have access to internet or any type of significant social media because of the geographic diversity and the limits of providing telehealth in these areas. Additionally, challenges exacerbated by health literacy makes the receiving, processing, and disseminating true and accurate information a monumental challenge, especially in our older demographics, 60 to 70 years of age. From a corporate standpoint, we managed to provide a unified approach despite the closure of our internal services. The services that we provided, including preventive health services, were deferred because of the limitations of providing access in-house. So we were required to provide most of our service out in a setting that consisted of our parking lot. So I wanted to leave the committee with recommendations on this experience and recommending a persistent and consistent outlook and perspective and continued funding in dealing with the issues of long-term COVID and the effects of COVID in communities such as the rural one that I serve. Looking at providing additional perspectives and infrastructure on telehealth for the delivery of healthcare to these outlying communities, and especially to look at the effects the pandemic has had on the pediatric population in terms of delayed delivery of healthcare services, the issues of specialty services for the community, and also to address workplace shortages that persist in the communities that are served by Indian Health Services under Health and Human Services. Thank you.
Thank you so much, Doctor. Dr. Riley, I'm now recognizing you for 5 minutes.
Thank you, Chair DeGette, Pallone, and ranking members for inviting me to speak with you today. My name is Dr. Laura Riley, and I'm an obstetrician gynecologist in chief at New York Presbyterian Hospital, Weill Cornell Medicine. As a maternal fetal medicine specialist and expert on obstetric infectious disease, I have dedicated my career to ensuring patients have healthy pregnancies. I'm a member of the Advisory Committee on Immunization Practices Work Group on COVID vaccines, and I currently serve as the chair of the American College of Obstetricians and Gynecologists Immunization, Infectious Disease, and Public Health Preparedness Expert Work Group. While many of my colleagues in other specialties were forced to delay non-emergent services during COVID surges, our labor and delivery unit remained operational at full speed, caring at great personal risk for our laboring patients. The ongoing pandemic has placed an incredible strain on our healthcare system and its workforce. Many labor and delivery units, including my own, are struggling with these mounting shortages. Obstetrics is practiced in a team, and when members of the team are missing, that can negatively impact patient care. While there is no one solution to these workforce challenges, greater investment in and training of healthcare professionals, from physicians and nurses to technicians, as well as efforts to diversify our healthcare workforce, are absolutely critical. The early days of the pandemic were a time of extreme anxiety and confusion, especially for our pregnant patients. Many were left wondering if they should attend their prenatal appointments and if it was safe to deliver at the hospital. During that time, it was essential to reiterate to my patients that it was safe to deliver and that their entire maternity team is committed to making sure that they get the support they need to birth confidently, safely, and respectfully. One of the most important healthcare system shifts during the pandemic was to increase the utilization and coverage of telemedicine. Remote visits have become an expectation of patients, and I strongly urge their continued coverage, including extending flexibilities such as audio only to meet patient needs. Additionally, an ongoing and urgent concern is our health system's failing of historically marginalized communities who are disproportionately impacted by the pandemic. A key lesson learned is that equity must be a focus of pandemic preparedness and response. The impact of COVID-19 on the patients I serve is significant and ongoing. When the pandemic first began, we worried, based on our experience with flu, that COVID-19 may be worse in pregnant individuals. Those fears were confirmed as we found that they are at increased risk of severe illness and death. Despite this evidence and urgent calls from the medical community, pregnant and lactating individuals were initially excluded from COVID-19 vaccine trials and continue to be excluded from therapeutic trials. That meant that when the vaccines became available, we had very little safe data on their safety and pregnancy, resulting in confusion and fueling misinformation. While ACOG and the CDC were finally able to make an affirmative recommendation for vaccination during pregnancy last summer, the long delay contributed to low vaccination rates among pregnant individuals and the rise of adverse outcomes. The COVID-19 pandemic is exacerbating the maternal mortality crisis. In September 2021, the CDC released an advisory following the record-breaking COVID-19 related deaths among pregnant individuals in a single month. Of note, their primary recommendation was to increase efforts to protect pregnant and lactating individuals through accelerated vaccination efforts. Unfortunately, vaccine hesitancy remains today, and I continue to counsel my unvaccinated pregnant patients on the vaccine's protection of their health and their newborn's health. These routine exclusions of pregnant and lactating individuals from research, presumably for their protection, leaves them disproportionately vulnerable and may have, in this instance, contributed to avoidable loss of life. As we reflect on the pandemic and lessons learned, it is past time to shift the narrative on research in this population. Instead of protecting them from research, we should be protecting them through research. Thank you for the opportunity to share my experiences and expertise with you today. I look forward to your questions.
Thank you so much, Doctor. And now, Dr. McBride, I'm very pleased to recognize you for 5 minutes.
Good morning, and thank you to Chairs DeGette and Pallone, and to Ranking Members Rogers and Griffin for inviting me today. My name is Dr. Lucy McBride. I'm here as a board-certified primary care physician in Washington, D.C. I've been practicing medicine for 20 years. I've dedicated my life and my career to helping people understand the inseparability of mental and physical health, whether it's my teenage patients or my octogenarian patients. I trained at the Harvard Medical School and at Johns Hopkins Hospital. I'm not here today, to be clear, with any political agenda whatsoever, but rather to share my perspective on the pandemic as someone who has seen patients every day, patients who are on the receiving end of complex and often confusing public health information, and who are trying to make sense of the news. This is a watershed moment of the pandemic. We've learned enormous amounts about the virus over the last 2 years. We've learned exactly who is most susceptible to the severe consequences from COVID-19, and we have now incredibly safe and effective vaccines and therapeutics. But we are not done. COVID continues to cause widespread death and destruction. We have a lot of work to do to increase vaccine uptake. We've also unmasked major problems in our healthcare system, in particular, the erosion of trust in public health and the lack of access to needed medical care just when people need it most. As a result, we're dealing with a parallel pandemic of mental health and crisis and surging rates of underlying conditions like obesity, and people just don't know where to go for advice. I've seen everything over the course of the pandemic. I've had patients hospitalized from COVID. I've had patients die from COVID. I have patients with long COVID. I have patients with COVID right now. I've also witnessed the social, emotional, and mental health toll of the pandemic itself and from all of the losses that come along with losing friends and family members to the virus, but also from lost jobs, sense of normalcy, social disruptions, isolation, and loneliness, and just from navigating the deluge of information coming at people every day and the politicization of science. I see the emotional distress and the very real physical manifestations of stacked stressors, from insomnia to stress eating to substance use disorder, and the accompanying surging levels of medical conditions like diabetes, obesity, and depression. What I see in my patients every day is mirrored in the medical data. Take, for example, my patient from earlier this week, a single mother with 2 children, one a middle schooler with special needs, and the other who is a college student suffering from depression. Stressed to the max, my patient finds herself drinking too much, eating, not exercising, and as a result, her blood pressure and her weight have soared during the pandemic. Naturally, she worries about COVID-19, but that's only one of the myriad health issues that she and I are working on together. So I'm here to bring my firsthand appreciation for what I'm seeing and for what I see people needing most, and that's access to a trusted primary care provider, something that 80 million Americans do not have, particularly in rural and poverty-stricken urban areas. Of course, I'm a little biased because I am a primary care doctor myself, but really, COVID-19 is an outpatient disease. The ERs and ICUs have obviously been critical for our most sick patients and are certainly where the news focuses and where doctors like Meg and Ranney have been doing heroic and essential work. But the fact is the vast majority of patients with COVID-19 are out in the world and not in the ICUs. ERs were flooded not only because people were severely and sometimes critically and fatally ill, but also because they were scared and sick and navigating the pandemic alone without access to a guide. So there are 3 unmet needs that I see in the community that we need to face. One is all the misinformation we're seeing. More than ever, people need a trusted medical provider to receive fact-based, nuanced medical advice. Just last month, a study in JAMA showed that the COVID vaccine uptake increases with the number of PCPs per capita. Number two, it's a place to manage underlying conditions. We know that in addition to age, one of the biggest risk factors for severe outcomes from COVID is underlying conditions. And we manage those, not with ER visits, but rather with longitudinal relationships with a primary care doctor for guidance on things like nutrition, sleep, exercise, stress management. And three, people need a place to help apply broad public health advice to their unique lived experience and situation. I spent countless hours on the phone over the last 2 years helping people manage everyday questions. Which COVID test? Which vaccine? Do I need a booster? And people need help navigating these everyday decisions and balancing risks. There's no better role for primary care than in a global health crisis. My hope is that our children grow up in an America where they have unfettered access to primary care, a hub for problem solving, a place where mental and behavioral health and physical health meet, where people can be fully seen and heard, and where they don't have to worry about who to trust. They don't land in Dr. Ranney's ER because they have underlying health conditions aren't managed. And when they're short of breath, they don't have to wonder, is this COVID or is this a panic attack? Where they can get their COVID test and talk about their anxiety and navigate that mental health condition that's so common. As we dig through the rubble of the pandemic and prepare for the next one, we must invest proactively in medical systems founded on relationships, rapport, and reason. Investing in primary care is the way we invest in our health and our collective well-being. Thank you very much.
Thank you so much, Doctor, and thank you for your work on the front lines. Thanks to all of our witnesses for their hard work. It's now time for members to have the opportunity to ask you questions, and so the chair will recognize herself for 5 minutes. You know, when we hear the testimony today from all of our witnesses, and when we hear from our constituents in our districts, we know that this crisis is impacting healthcare workers across all levels, from primary care physicians to nursing to emergency care and on and on. And only when we understand where we fell short can we better understand what we need to do for the future. As the chairman said, I'm all about recognizing the positives and the challenges and seeing what we need to do. And so what I want to do with our witnesses today is drill down in what the witnesses feel are the critical steps for Congress and the federal government to take to prepare for tomorrow's challenges. So Dr. Ranney, I'm going to start with you first. Your testimony mentions needing a, quote, culture of preparedness to effectively manage national disasters. What one action do you think would be key to being better prepared in the future?
Thank you for the question. So I'll note that organizations like ASPR have previously outlined good preparedness plans, ways to set up healthcare systems that have adequate resiliency with staff, with supply, with real-time data, to be able to respond, identify surges when they start, respond appropriately to stop them from getting worse, and then to deploy healthcare workers across the country as needed. Right now, we need to shore up our workforce. So that's both about retaining current healthcare workers, helping them individually manage their burnout and morals distress, stopping or reducing the impact of workplace violence, and creating those systemic fixes so that we have, particularly for our nurses, having adequate nursing staffing ratios, and about training up new healthcare providers so that we can refill the ranks from all the folks that have left. And then the third part is working on creating new models of access to care. I do appreciate Dr. McBride's points about primary care providers, the minority Minority Griffith members' comments about telehealth. Also, new digital health modalities as well can make a big difference. And then at the bottom of it, setting up a better data infrastructure. So the wastewater monitoring that CDC is now beginning to implement into its data systems are critical. Setting up other data systems that we have accurate information, not just on race, ethnicity, and age of cases, but also hospitalizations, so that we have real-time data on staffed hospital beds, so that we have real-time data on supply shortages. Again, personal protective equipment.
I'm sorry, I'm going to need to interrupt you so I can
No problem.
get to the rest of my questions. I want to ask you, Ms. Austin, the same question. What do you think we need to do to support nurses and address the challenges in the future? Okay, I'll come back to you, Ms. Austin. I think we're having a technical issue. I want to ask you, Dr. Riley, you've noted the availability of vaccines and treatments that were instrumental in supporting the health and well-being of your patients, but there was a delay in the evidence necessary to assure safety and efficacy among pregnant and lactating women. Briefly, what can we do to recommend to address this in the future?
I think, thank you for the question. I think it's really important that we figure out how we're going to involve pregnant and lactating women in research earlier in the process. Research could have been done on the vaccine, getting us information about safety that would have allowed us to vaccinate even more women. The long delay allowed us to then fill that in with the mistrust and all sorts of things on the social, which have led to fewer pregnant women being vaccinated than we would hope. I think the other issue that we need to really focus on is that there are surveillance systems which in the past did not include information on pregnancy and lactating women. And those surveillance systems, which have now been stood up for COVID-19, need to remain in place. So not only do we need surveillance of disease, we also need surveillance of vaccine use and vaccine safety, which are absolutely critical. Thank you.
Ms. Austin, do we have you back?
Yes, I apologize. I lost audio for just a few minutes there. Thank you so much.
Technology's our friend.
And
Go
I did miss
ahead.
the question.
Go ahead. The question was, what steps do you think that we can take to support nurses and address the challenges we found with COVID?
Yeah, I think the biggest opportunity for our nurses, I hear all the time, it's our staffing shortages. I think if there's anything at all that could be done, is just investing in our accredited nursing residency programs. Emory has one of only 2 nursing residency programs in the state of Georgia, and it is truly a pipeline for us. Over the last couple of years, we've brought in about 500 new nurses, new graduate nurses, and our goal this year is to bring in over 700. So I think that anything that can be done to help partner with the federal government to grow our program would be really helpful.
Thank you so much. Dr. McBride, I'm out of time, but my daughter is a primary care doctor in San Francisco, and I know the work that all of you do. I'd be interested if you could just very briefly tell us what Congress can do to help support primary care doctors going forward, because there's a severe shortage, as you say.
So right before the pandemic, we had an enormous shortage of primary care physicians, particularly as patients age and we have baby boomers and people are living longer. So here's my advice. First, we have a supply problem. We need to incentivize people coming out of medical school to come into primary care professions. Right now, the incentives are to go into specialties that are more procedural based, and we need to, in my opinion, I'm biased obviously, make primary care the kind of crown jewel of medicine, because it's the place, it's the ground game, it's where trust is born, it's where relationships and rapport are born, to be able to dispense trust and nuanced information. And if we have better primary care, particularly with behavioral health and mental health services woven in with PAs, NPs, doctors, and extensions of us, then we can do better to prevent mental health despair, physical health problems. And so it's about getting more people in medical school to go into primary care. It's also about
I'm sorry to interrupt you, but my time is way expired, and I appreciate the ranking member. I'm sure we can get more from you. Thank you. And I'm going to recognize Mr. Griffith for 5 minutes.
Thank you very much. I'm going to ask for a little indulgence too, because I want us to go back to Dr. Riley for just a second on one of your questions, because part of our duty is not only to get information for ourselves, but to make sure people back home who might be watching it on C-SPAN have an opportunity too. And Dr. Riley, you mentioned surveillance systems. Define that for us. You were talking about nursing and so forth.
So I was talking about having information on COVID infection specifically for pregnant women and lactating women. So that surveillance system that the CDC, ultimately stood up allowed us to then figure out that in fact COVID infection was worse for pregnant women.
I got that, but the problem
just
is I'm not sure folks back home understand what you mean by surveillance system that the CDC stood up. That's what I'm trying to get at. It's just a
Oh,
definition.
I'm sorry.
That's all right.
Okay, so a way of counting cases of, being able to recognize that the patients coming into the hospital are pregnant or not pregnant, lactating, not lactating, race, ethnicity. So getting more information on patients as they come into the hospital or as they leave the intensive care unit so that you can figure out exactly who's getting sickest.
Thank you very much. That's very helpful. Dr. McBride, at the beginning of the pandemic, the Centers for Medicare and Medicaid Services announced that all elective non-essential procedures should be delayed during COVID-19 outbreak. CMS also stated that the decision to proceed with these procedures would be made by the clinician, patient, hospitals, state and local health departments, et cetera. But as a result of that, patients and doctors across the U.S. postponed procedures. More recently, during the Omicron outbreak, some states and hospital systems continue to grapple with the decision to delay elective or so-called elective procedures to manage care for COVID-19 patients. Looking back on the decisions to postpone procedures, were there any options besides across-the-board postponements that we could have made?
So, as we all know, hindsight is 20/20.
Yes, ma'am.
But I do think it's important to realize moving forward, because we will have another wave of COVID-19, we will have another pandemic, whether it's in 6 years, 6 months, or 6 decades, to recognize that COVID is only one threat to our health and well-being. It's enormous, right? We've lost almost 950,000 American lives. People are suffering from long COVID and other sequelae from the virus. But I think it's also important to realize that elective surgeries, for example, are essential for people to keep people healthy, to prevent the underlying conditions that then put them at higher risk for poor outcomes. So I don't claim to have the solution, but I think we need to make sure that we gather as much information now on the virus, who exactly it affects, so that we tailor our mitigation measures more appropriately to the actual risk, and that we don't do more harm than good with mitigations.
And I appreciate that, because there are situations where harm was done. Because, as I said in my opening, most people, when they hear elective, they think you're talking about something that doesn't need to be done, or cosmetic surgery or something like that, when in often cases it's the diagnosis phase where you're trying to figure out what is wrong. And it may not appear to be an emergency today, but as we know, unfortunately, sometimes it is actually an emergency, or the test would have turned up something that needed to be dealt with right away. All right. Also, Dr. McBride and then also Dr. Riley, during the COVID-19 pandemic, healthcare providers had to adopt remote methods to care for their patients by using telemedicine. This is especially important in underserved and isolated communities where it is more difficult to access care. We know that telemedicine can save lives. I'm glad that the healthcare facilities in my district have taken advantage of the federal grant funds to enhance their capabilities. Did you use telehealth during the pandemic? And if so, what type of equipment did you need to use to monitor patients from home? We'll start with you, Dr. McBride, then we'll go to you, Dr. Riley.
Thank you for that question. So telehealth was a lifeline during the pandemic. I actually wrote an opinion piece in the Washington Post in the spring of 2020 with the former FCC Chairman Reed Hundt about the urgent need to get universal broadband access to all Americans, particularly, as you said, for those in rural communities and marginalized communities who don't have access to internet service, which right now is a beautiful adjunct to, for example, primary care, particularly with mental health care, which, as you know, is a surging and crisis in this country. You know, in-person therapy, in-person Alcoholics Anonymous is probably better than virtual, but virtual therapy and virtual AA is better than no therapy and no AA. So if we can get people the access to the internet services they need, then we can reach the far corners of
And I
America.
agree with that. What did you use in your practice, or what did you need to update or improve in your practice to make that
We had
happen?
to do a Control-Alt-Delete on how we practice medicine, if you will. So basically Zoom and Microsoft Teams, we had to, I remember the days of getting my 92-year-old patient, for example, to log in to Zoom and do the passwords. I became a tech support in addition to a doctor, trying to help her manage her sore throat. Is it COVID? Is it something else? On Zoom. So, we need better tech capabilities. We need better tech support not just
All right.
doctors, and we need
And I have
access.
to cut you off because my time's up. And Dr. Riley, I'll probably ask that as a written question. If you could give me your answer in writing to those questions, I would greatly appreciate it, but I must yield back.
I thank the gentleman. All the members of Congress also became tech support experts as well, Doctor. Chair now recognizes the chairman of the full committee, Mr. Pallone, for 5 minutes.
Thank you, Chairwoman DeGette. I wanted to ask Ms. Austin initially. You stated in your testimony, and I quote, "The COVID-19 pandemic forced our nursing workforce to find new and innovative solutions to the challenges brought on by this public health crisis." So if I could ask you, do you think the availability of new tools such as the COVID-19 vaccines and treatments has helped your team and other nurses in the country keep these challenges from being worse in the United States? And if so, how?
I would say yes to that. You know, our nurses really appreciated the opportunity when our vaccines came out. They appreciated the opportunity to take the vaccines. They appreciated the opportunity that there were patients, family members that were taking the vaccine. Because again, you know, what nurses are fearful of, most of them, is being exposed and having to take, you know, the virus home to their family members. So I think that vaccination is for most nurses is appreciated. And I do think it helps with the complexity of all the other things that they're doing. It's one less thing to worry about while they're trying to take great care of patients.
Thank you. Dr. Riley, your patients have had specific needs in thinking about their own safety and health and that of their families for the past 2 years. What's the availability, well, what has the availability of COVID-19 vaccines meant to your patients, Dr. Riley?
It's been tremendously helpful to patients. I think for those who have availed themselves of the vaccine, I think that there's good data to suggest that it certainly has helped them personally. So women are less likely to become ill and land in the ICU if in fact they are vaccinated, pregnant and vaccinated. I think also we now have good data that suggests that the antibodies that those women make after vaccination are transmitted to the newborn and can be protective for newborns who can sometimes get sick. So I think that, patients who are unvaccinated are the ones that we're really trying to target now so that they can protect their own health as well as the health of their babies.
The committee has supported a range of legislation intended to support healthcare workers and the broader health infrastructure, including $48 million in funding recently made available by the American Rescue Plan for community-based organizations in rural and tribal communities to expand public health capacity. So, Dr. Caddlek, I wanted to ask you, how critical are the investments such as those in the communities you serve with the Indian Health Council?
Thank you for your question. Those needs are critical. I would like to segue off of Mrs. Austin's question in terms of nursing, the importance of nursing not only in facilities and in hospitals, but also in public health settings where you send out nurses to these rural communities to support the needs of patients that cannot come in or cannot have access to a telehealth platform and receive the care that they need. So in terms of the continued funding supports for healthcare workers, it's critical that we not only look at nursing, but also other forms of healthcare providers, including physicians. I might just support and recommend programs like Indians into Medicine, which is the 5-year program looking at providing funding for Indians going into medicine, and quoting the 2017 Association of American Medical Colleges data, where we had between 2012 and 2017, 93,000 medical graduates, and only 131 of those were identified as American Indian and Alaska Native. So 93,000 and only 131 physicians that would potentially go back to the communities to serve those rural areas that we just spoke of.
Let me just one more question of Dr. Ranney about, we have a number of, we have passed legislation to address behavioral health and how that impacts health providers. Dr. Ranney, how do these targeted investments in behavioral health or the behavioral health needs of healthcare professionals, how important to them, if you just would comment on that?
So briefly, they're just tremendously important. The Lorna Breen Act, which obviously was named for one of my fellow emergency physicians who killed herself after taking care of COVID patients and then catching COVID herself in the early days of the pandemic, is just a tremendous step forwards. In the face of burnout, PTSD, depression, so many healthcare providers are leaving. And as the other witnesses testified, a teammate's departure isn't just about losing that staff member, it's also about the overall culture of the team. So providing individual level support, reducing stigma to getting that support, encouraging state medical licensure boards and hospitals to not ask about behavioral health treatment when licensing. Those are all critical steps to helping us be healthy so that we can better take care of our patients.
Thank you, and thank you, Chairwoman DeGette.
Chair would like to remind all of the members who are appearing on WebEx that they need to mute themselves, when, both the witnesses and the members. We're getting feedback because people aren't muting themselves. Thank you. Chair now recognizes Mrs. Rogers for 5 minutes.
Thank you, Madam Chair. This will not be the last pandemic we face, and I believe that it's critical that we learn from our response to not only prepare us for future pandemics, but to ensure we do not repeat the costly and harmful policies that we've seen over the last couple of years. To that end, Johns Hopkins recently published a report that lockdowns had little to no effect on COVID-19 mortality, but certainly brought significant social and economic cost. Dr. McBride, in your written testimony, you speak to this and you note that we failed to tailor our mitigation efforts to those highest at risk. Can you please explain how this happened and why it was especially harmful?
So I think in the panicked spring of 2020, when we didn't know much, if anything at all, about the novel coronavirus, it arguably made sense to do everything we could, right, to prevent all of the widespread death and destruction. I think the two biggest failures in my mind in the public health response were the closures of schools and the prolonged closures of schools. We know now that in a public health emergency, schools should be the last to close and the first to open. And we imposed very strict interventions on children who we now know face the lowest risk of any age cohort for severe consequences from COVID-19. That is not to dismiss the ongoing suffering of families who have lost children to COVID-19. The death of a child is tragic, regardless of the cause. And it's not to dismiss kids with long COVID, with MIS-C. It's not to dismiss any of the devastation. It's simply to say that closing schools has done harm to our youngest generation. And secondly, the other major public health failure in my mind was that we did not protect our most frail elderly patients as well as we could in the early days of the pandemic. We know that there's a log-fold increase in risk of severe consequences and death from COVID that goes with age. And we could have done things like paying home health or nursing home aides to work at one nursing home facility instead of many, because they were unwittingly spreading the disease, even though they were trying to help protect their patients. And so I think, as I said earlier, hindsight is 20/20. I do not ascribe malintent to anyone. I simply think that it's really important moving forward because, again, we'll face another pandemic, we'll face another COVID wave, that we tailor our mitigations and we appropriately calibrate the risk mitigation measures to the population at risk, and then arm people with tools and information to use to protect themselves. Again, I'll go back to my main argument in my testimony. This is another reason why we need primary care hubs. We need patients to be able to pair the broad public health advice with their unique lived experience, age, underlying health conditions. We could do a lot better the next time around.
As a mom, I really appreciate your voice. You're fighting on the front lines to get our kids, our children back in school. Just as a follow-up, do you believe it was foreseeable? You talked about the impact of the prolonged closures of schools. Do you believe it was foreseeable?
I think we know that school is essential not only for learning, it's also essential for kids who aren't safe at home. Kids don't always come from a happy, healthy home. Kids use school for their food, They need it for their emotional health. They need it for social bonds. That's where kids get their athletic activities. We've seen surging rates of obesity in children, in part, not fully, but in part because kids have been relatively inactive and on screens much more than they were pre-pandemic, although I'm a mother. I know that screens are not an easy problem to solve, but I think it was foreseeable that school closures would cause harm. I think we thought that this was going to be a short-term, 2-week, flatten the curve proposition.
Yes.
But here we are 2 years into the pandemic.
Yes.
We have so much accumulated data on who's at highest risk.
Yes.
And I think we need to really
Before I
dig
run out of time, would you just speak briefly, if you've reviewed the data at CDC around the mask mandate on our kids and its impact?
Sure. No, I've looked very, very closely at the mask mandate data. And what I would say is that there's no real world compelling evidence at this moment in March 2022 that mask mandates in schools have meaningful effects on the transmission of the virus in the schools. That is not to say that masks don't work or can't work. I am not anti-mask. I was wearing a mask all day yesterday in my office seeing a sick patient. It's simply to say that the burden of proof is on the intervention. The norm is to see faces in schools, to see the broad range of expression on teachers and coaches and mentors' faces and on peers' faces. It's to say that there are unintended harms of a mandate, for example, on children who are autistic, children who have speech and language delays, children who have English as a second language, and even for neurotypical children, seeing people's faces is the norm.
Thank
so
you.
any intervention that we impose, particularly if it's mandated, needs to have more benefit than harm.
My time has expired. I appreciate a little extra time there. I yield back.
Chair now recognizes Ms. Custer for 5 minutes.
Thank you. And I just can't resist going back to the last witness. We all would love to have the children in schools, and certainly now, and we'd all delighted to get rid of our masks. Do you think if the previous president had taken the vaccine publicly a year ago when he chose to take it privately and not tell anyone, that would have made a difference in vaccine uptake and would have ended this pandemic earlier?
I think,
That's to the previous witness.
is that for me?
Yes.
Absolutely.
McBride.
I think if the previous president had modeled vaccine confidence, it would have made an absolutely a big difference. And one of my jobs in medicine
It would have saved hundreds of thousands of lives, possibly, and certainly would have saved many, many children from the harm. So I'll dive back into my remarks, but I can't leave that unsaid. Like many places throughout the country, my home state of New Hampshire faced a surge caused by Omicron over the last few months. And at one point in December, there was not a single available bed in the 5-state area in our region. I spoke with hospital leaders across my district in December who detailed the serious impact of COVID-19 on workforce, bed availability, and delays in healthcare. And in my own family, we have had delays in healthcare directly related to the COVID surge. Like all Americans, I'm glad to see that the Omicron surge is largely behind us, but it must be underscored that this surge and the tragic deaths that followed were driven overwhelmingly by unvaccinated Americans. Throughout the pandemic, hospitals and healthcare providers have had to delay elective procedures to be able to respond to surges in COVID-19 cases and hospitalizations. My own brother's surgery has recently been delayed. Hopefully it will happen today. But all of us are scrambling in our families to rearrange travel schedules and to try to be there for those who we love. Dr. Ranney, your testimony mentioned colonoscopies, heart surgeries, and even brain surgeries as the type of surgeries postponed or disrupted. Can you give us a better understanding of the types of services that are considered elective, and what are some potential implications of delaying these procedures?
Thank you, Representative. So to be clear, again, these elective surgeries are not cosmetic. They are things that are utterly necessary. It is about removing a pituitary mass, a mass in the brain that's threatening your sight. It's about removing cancer. It's about repairing an aorta before it bursts. And what happens when these surgeries get delayed is that they triage according to what's the most likely to be most life-threatening. Those are the ones that get moved up. So I know of many patients who had their surgeries delayed, ended up with emergent conditions, ended up in my ER, and then we had to make space for them. The trouble was, though, is that so many of our nurses were redeployed to take care of COVID patients that we couldn't adequately staff post-surgical ICU beds. And this was true, of course, not just in my own hospital system, but in others across the country, which then created a knock-on effect of having to keep patients in the emergency department longer before they could get the surgeries. One of my colleagues actually in Wisconsin recently told me that he's diagnosing more advanced cancer now and recurrences of cancer than he ever has because of folks having to put off these procedures, imaging studies and so on, due to COVID and due to the staffing limitations therein.
And in our situation, I'm having to fly across the country tomorrow evening because they won't keep my brother in the hospital post-surgery because of COVID. So this is really impacting people's lives. Studies confirm patients also made the decision to delay medical care, and you've mentioned that. A CDC study earlier in the pandemic found 4 in 10 adults delayed or avoided care, including urgent and emergency care, a trend that's continuing. What is, you've mentioned delaying care and the consequences, but I'm wondering, delaying screenings and preventative care, if you could review the consequences on both patients and the healthcare delivery system.
Absolutely. So early in the pandemic, when our COVID visits were high, overall number of visits dropped. That's also happened during the Delta surge and during the Omicron surge. And what we found was actually in parallel, number of at-home cardiac arrests increased, number of strokes that we couldn't treat increased because people stayed out when they really should be coming in to get evaluated. We're also seeing delays in things like dental care that result in people coming in with major cavities or tooth abscesses. We're seeing delays in diagnoses of cancer. And of course, we are seeing increases in untreated behavioral health problems, opioid overdoses and the like, problems that pre-existed before the pandemic, but have worsened over the last 2 years.
And we do
Thank you so
intend
much.
to pivot to that.
General Lady's
Thank you.
time's
My
expired.
time is up. I yield
Mr.
back.
Burgess?
Thank you. Thanks to our witnesses for being here today. This is exactly the type of hearing that we should have been having over these last 2 years, so I'm grateful that we're having it. I hope this is not the last. I hope we will continue to do this type of work because, as you'll recall, the congressional approach to the pandemic were massive supplemental emergency appropriations, but we're an authorizing committee, and we're supposed to do the work. We're supposed to take the testimony from the experts and come up with how the money is most correctly to be spent, and then the appropriators write the check. But these last 2 years, we've written a lot of checks without doing the groundwork ahead of time. So we can do some of it after the fact, but Congressional Budget Office was in my personal office earlier this week, and they said there is, I think, around $350 billion of unspent, unobligated funds in all of the appropriations packages we did as emergency measures over the past 2 years. So when I hear discussion about we need more money for this, for that, I don't disagree. But that's because this committee has not done the authorization work that it should have done over these last 2 years. Now, having said that, let me, Dr. Riley, I will not get through every question that I've got to get through, so I will be submitting some of these questions in writing and look forward to your responses. But Dr. Riley, if I could ask you, we actually have a doctor's caucus here in Congress. The Surgeon General came and talked to us a couple of weeks ago. He said doing his rounds around the country, he was very concerned about physician burnout, as am I, as all of you. But one of the things that's sort of left unmentioned is every year we turn around and we start cutting Dr. McBride's pay and Dr. Riley's pay because of the physician fee schedule in Medicare. So I'll just ask you, Dr. Riley, do you think if we as a committee would spend the time addressing issues like provider pay, that that would help some of the workforce issues and the burnout issues?
Thank you for the question. I suspect yes. I mean, I think that, people want and deserve to be compensated for the work that they do. I do think that there is also the opportunity to incentivize certain aspects of medicine. I think that we're facing a really important challenge right now where every aspect of healthcare, whether you're a physician, a nurse, a technician, a genetic counselor, et cetera, all of those people are absolutely critical to what we do, but all need to be compensated. And there's quite a bit of, technical education that needs to go into that. So yes,
Yes,
I do think that.
and
that's part of it.
I'll have to move on because again, time is so short. So Dr. Ranney, I had a question for you. I've got a hospital, it's not in my district, it's just outside of my district. And as everyone knows, with coronavirus, we do have some things that can be administered as an outpatient. That's a wonderful benefit. Once someone gets sick enough to be in the ICU, once they've had the course of steroids, well, after they've failed remdesivir, there's not much on the shelf to be able to administer to those patients to try to save them. There is work going on. In fact, one of the hospitals just outside of my district is working with a compound called Zyasmi that is a vasoactive intestinal peptide, which seems to show a lot of promise just in general. And this is what's been so frustrating with the FDA through this pandemic. You get something that's in a phase 3 trial, so it's more likely than not to be beneficial. You've got nothing else, and a sick patient in the ICU on the ventilator. So what about the access to late-stage therapeutics in coronavirus patients who are in critical care?
So I think the emergency use authorization, thank you for the question. I think emergency use authorizations are a critical tool for us to use during a pandemic to improve the speed at which we have access to therapeutics that have good safety data and decent efficacy data. I don't want to spending time.
Yeah, I got to interrupt you there because I agree with you. The problem is this particular compound, that application is gummed up in the FDA. They might get to it in September. We have situations where it's not the regulation, but we have personalities that we can't get past. And that's one of the things that needs to change as we go forward in this pandemic. I thank all of our witnesses for being here. I know how valuable your time is. I'll yield back to the chair.
Thank you, gentlemen. Ms. Schakowsky, you're now recognized for 5 minutes.
Thank you, Chairman DeGette, and I appreciate your holding this hearing. We owe our nurses and doctors and all of the frontline healthcare workers an enormous debt. And the title of this hearing, Lessons from the Front, really drives home what I believe is the point that we have to listen to our healthcare workers and give them the supplies and the support and the resources that they are asking for. And though they're not here at this hearing today, I want to recognize that the labor unions that represent frontline healthcare workers have provided a path for critical health and safety protections for workers and for patients. And for this reason, I would ask to put into the record a December 2021 report from National Nurses United, the largest national union representing registered nurses from around the country.
Without objection, so ordered.
Thank you. The nurses and healthcare workforce is in crisis. And it has been for actually a long time. And we know that there is a shortage of good paying permanent nursing jobs where nurses are fully valued and their work for their work at the bedside. And this is exactly why we need to invest in permanent jobs with good wages and benefits and safe staffing standards. I am very proud that I have introduced legislation and leading the legislation called Nurse Staffing Standards for Hospital Patient Safety and Quality Care. I'd like to ask Dr. Ranney, in reviewing your written testimony, I noted that, I noted and appreciate actually that you referenced the dire need to implement minimum nursing standards. And I wondered if you could talk more about the science and the evidence that, that backs up the need to have minimum nursing staffing ratios.
Absolutely, and I can share specific studies after the hearing. I don't have all of the exact numbers at my fingertips, but the short version is that there's ample evidence that having low nurse-to-patient ratios improves patient outcomes, decreases patient mortality, decreases staff burnout, not just for nurses, but also for the rest of the team. Asking nurses to take care of more than a certain standard number of patients with a lower number of patients acceptable in the intensive care unit compared to on hospital floors. But going past that limit increases, again, both patient harm and nurse and others burnout.
That the lack of the any kind of staffing ratios and is a reason for burnout of nurses, that they just feel overwhelmed. And we do see a flight of nurses that was mentioned by one of our other witnesses, and that would help to keep people on the job. Dr. Ranney?
Absolutely. Thank you. That would absolutely help to keep people on the job. Speaking to nurses that are in states that have nursing staffing ratios versus those without, there's a really big difference in terms of their quality of care provided, their levels of burnout, and their willingness to stay there.
So I really appreciate that, but because we're talking not only about the nurses themselves and their ability to stay on the job, but I think the data that you referred to that shows that the outcomes for patients really improves. I've talked to nurses who are so worried that they have not been able to make sure that the medication is correct, and we know that there is a good deal of harm that happens in hospitals that some of which can be attributed to the fact that the nurses can't spend enough time. So I just thank you for that, and you know, we want to do everything we can to make sure that both the workers and the patients have what they need as we go forward. And so I yield back. Thank you.
Thank the gentlelady. Mr. McKinley, you're now recognized for 5 minutes.
Thank you, Madam Chairwoman. Lessons learned from the pandemic. There's several things that I'm going to try to get through in a short time. Several of the hospitals in West Virginia have indicated that they seem to have increased efforts to hack into their hospital records. I don't know whether that's unique to West Virginia. Has it been for any that went on the panel? Have they seen that across the country during this pandemic, that people were trying to get access to health records? Can anyone comment about that just quickly? Hearing none. Let me go to Austin.
This is
if I could,
Dr. Ranney, just to say that the issue of cyber attacks on healthcare records is an issue that's been going on for a very long time, and I can provide data from Dr. Paraxis.
Increase, has there been an increase in this? That's what I'm trying to get to. So if I could.
I'm not sure. I will find out.
Okay. To Austin down in Emory. We've had, my wife was a critical care nurse for 45 years, and we've known about this shortage of nursing care for some time. But during the pandemic, there was a call or demand for increased nursing care, and so the traveling nurses really took off on this. And so hospitals like Emory or all the way, the larger hospitals all across America are paying, I know we have records of it, as much as $200 an hour for the first 1,000 hours that they work. That's exacerbating the shortage that Chakowski just talked about. Larger hospitals can afford to pay that. But rural hospitals like we have in West Virginia and in Eastern Ohio or elsewhere, rural areas, can't compete with that. They're being robbed of their nurses. So I'm curious, what is the solution they can't afford to pay more, or they would have been doing that. How are small hospitals supposed to exist during a pandemic when their nurses are being robbed to go someplace else? Can one of the panelists comment about that?
Thank you for that question. I'm happy to. I'd like to acknowledge and thank your wife for her many years of nursing service. I think that's the question that you asked is a question that all hospitals are asking themselves, whether it's a rural hospital or a larger hospital in a metro city. One thing I talked about earlier is the ability to bolster any types of training programs to actually increase the nursing pipeline. I think could be really helpful. That way we can decrease, I think, the dependency on contract labor. Contract labor is not sustainable. In my healthcare organization, we are having a lot of conversations about how to mitigate the labor costs for travelers. I mean, it is, in the beginning, it's meant to be a very temporary way to supplement, say, nurses that are on leaves of absences. It is not a way that we want to staff our hospitals because, again, I say it's just not sustainable.
Thank you very much. Let me reclaim my time. I'm trying to get two quick questions. During the pandemic, also, there was a shortage of PPE. And we were seeing companies like Premier that were trying to level out to make sure that it was distributed. But yet this committee, or the Energy and Commerce, has before it a bill that's going to restrict it. We know we need more plastics, but yet we have in this committee an effort to try to restrict increased plastic production in America. It just doesn't make sense to me. So what they're talking about it was a Clean Future Act under Section 902 says for the next 3 years there will be no new plastic manufacturing in America. I think it just befuddles me as to why we would do this when we need the plastic. But Dr. McBride, I want to turn to you just at the last of it and say, because of the children with mental health, I'm curious to see what we're saying for schools. Are we going to continue to depend on our teachers to try to take on the mental health issue? Can you talk to me a little bit? Because this is very frustrating when I see, as we come through the pandemic, how we deal with this.
Absolutely. I mean, teachers are some of the unsung heroes of the pandemic.
Yes.
We owe a debt of gratitude for our frontline health workers, our essential workers, our teachers. We cannot ask teachers to be mental health providers. I mean, I think one of the reasons, at least the teachers I know and care for as patients go into teaching is to be not only someone who educates children, but also a mentor and a guide and provide emotional support. But in order to help children, recover from the stacked stresses of the pandemic, regardless of their lived experience, and in order to bolster their mental health moving forward, we need to make sure that educators are aware of mental health issues. And here's an idea that one of my friends works in DC here. She's a pediatrician, and her clinic is annexed to Anacostia High School. If we can build in primary care and annex it to schools, particularly schools in marginalized, underserved, often urban communities, where people can get vaccines, where they can get basic primary care, and they can get access to truthful information right in the school setting. That would do a lot to bolster the mental and therefore physical health of children and adolescents. Make it easy to get access to mental health care, even at school or annexed to school, because teachers cannot do, they're wonderful, but they can't do everything.
Thank you.
Chair
now recognizes Mr. Tonko.
Thank you, Madam Chair. The pandemic has adversely impacted our nation's healthcare workers and leading many to experience work overload, burnout, and feelings of anxiety or depression. In addition to what we've heard this morning, a survey of pandemic frontline healthcare workers found a majority experienced worry and stress negatively affecting their mental health, with 3 in 10 needing mental health services as a result of the pandemic. This is one of the reasons that I've introduced H.R. 1716, the COVID-19 Mental Health Research Act, along with my colleague and friend, Congressman Katko. This bipartisan legislation would fund research to study the effects of COVID-19 as a pandemic and what its effect it's had on the mental health of Americans, including its impact on healthcare providers. So, Dr. Ranney, as an ER doctor, I imagine that workplace stress is commonplace. Can you describe how the pandemic has impacted the mental health of emergency physicians and what you mean by, and I quote, moral injury that you make mention of in your testimony?
Thank you for the question, Representative. I have stories in my written testimony around the effects of both treating COVID positive patients for 2 years on end and the effect of the continued staffing shortages on the emotional health of frontline providers. It's things like not being able to care for your patients because you're too busy with others. It's about having patients wait out in the waiting room who you know are desperately ill, but who you simply can't get to because there aren't stuffed beds back in the emergency department. Moral injury is really a concept that derives from wartime. It's the idea of being exposed to or having to make choices that go against the moral fiber of your being, that go against how you were trained, your faith, your sense of integrity, simply because you have no other options. And that's what healthcare providers have faced over and over during the pandemic. We've been forced to make decisions that we would not normally make, that we know are hurting patients or their families, simply because there is no other choice, because there is no space, because there are no staff, because there are no optimal medications, or sometimes because the equipment that we depend on is not available. It is at this point in the pandemic, a totally preventable occurrence if we had adequate staff and adequate supply chains.
So, that being said, Doctor, what can we do to, beyond that, better support healthcare workers during this pandemic and beyond?
Thank you, Congressman. So there's a combination of individual level support. Again, things like your bill, the Lorna Breen Act, some innovative projects that are being done at hospitals around the country. I highlight in my testimony Project Cobalt that's been developed by colleagues at Penn to provide digital therapeutic support to healthcare providers. It's about destigmatizing reaching out for mental health care and behavioral health care. But most of all, it's about supporting us in our daily jobs. Those individual level solutions are important for helping those of us that have been there. But what we really need is things like loan repayment programs, increased staffing, improved ability to honestly just support our patients, do our jobs, and support their families.
Thank you. A study by the Occupational Safety and Health Administration found that prior to the pandemic, healthcare workers were already 4 times as likely to face workplace violence, such as physical assaults or threats, than workers in private industry. Since the pandemic, we've seen disturbing reports about verbal and physical abuse directed toward healthcare workers. Some hospitals have even had to issue panic buttons to their staff. Ms. Austin, the nurses often bear the brunt of this abuse. In fact, as you mentioned in your testimony, nurses have been verbally attacked for implementing COVID-19 safety restrictions, and patients' families take their emotions out on nurses. Did your nursing team witness an increase in verbal and physical attacks over the last 2 years? And if so, how have you and your colleagues coped?
Yes, we have. One thing that we've done here at our hospital is we've instituted a workplace violence prevention team. We've encouraged our nurses to report every instance of either verbal or physical abuse. Oftentimes what we found is that nurses believe that, this is just what's supposed to happen, and they take on the verbal, usually not the physical, but the verbal abuse, they will let go. And so we've done a lot of work to encourage nurses to report every single instance. Our workplace violence prevention team will respond to every single instance to ensure that our nurses are supported, to make sure that we've had conversations with patients. We've involved our public safety department if that was necessary. We make sure that our leaders are rallying around our staff so that they know that they have full support from our hospital around these types of instances.
Thank you very much. And Madam Chair, I yield back.
I thank the gentleman. Chair now recognizes Mr. Palmer for 5 minutes.
Thank the witnesses for being here and for the chairwoman holding this hearing. One of the things that I think has been touched on a little bit is the impact of the lockdowns on school children. But I haven't heard anyone talk about this, Dr. McBride, the surge in teen suicides. we've seen a record number of teen suicides. It got so bad in Las Vegas that it forced the Las Vegas schools to reopen. I know that the medical community's been overwhelmed with treating COVID patients, but added to that are the complications of being locked out of jobs, being locked out of schools, being cut off socially from peers and friends. Hasn't that added to your workload? To Dr. McBride, yes, thank you.
Absolutely. I mean, I think it's important to recognize that ER visits for mental health concerns, suicide rates, cannot possibly measure the breadth and depth of people's despair as defined by having depression, anxiety, OCD, PTSD, substance use disorder. I would also say, to make it clear, that there are many, many roots of people's underlying health conditions in the mental health sphere. In other words, people have lost loved ones to COVID-19. Mm-hmm. That's a trauma. People have also lost a sense of normalcy in their fourth grade classroom. That's also a loss. So I think that the roots of the mental health crisis are broad and varied, but I think it's not a coincidence that the Surgeon General...
Let me ask for a little clarification here, because when you start talking about how broad it is, that implies that there are underlying conditions that may have been made worse by the lockdowns. But that's true of physical health as well.
Sure.
So the bottom line is here, and I'm looking at this Johns Hopkins. It's not a report. It's an assessment of existing research. And I just want to read what it said, that the lockdowns during the initial phase of COVID-19 pandemic have had devastating effects. They have contributed to reducing economic activity, raising unemployment, reducing schooling, causing political unrest, contributing to domestic violence, undermining liberal democracy. These costs to society must be compared to the benefits of lockdowns, which our meta-analysis has shown are marginal at best. And then it concludes with this: such a standard benefit cost calculation leads to a strong conclusion. Lockdown should be rejected out of hand as pandemic policy instrument. And the thing that bothers me about this is that we knew this before this report came out. And as a consequence, I mean, there's all kind of research out there and studies that showed that we had this surge in teen suicide, particularly among women. We had teachers quitting. We now, you talk about a shortage of healthcare workers, we now have a shortage of teachers. And a lot of it has to do with the lockdowns. Dr. McBride.
So I think you're absolutely right that lockdowns have done enormous harm on our social fabric, on our economy, on our physical health. And I think it's not a coincidence that the Surgeon General has issued a concerning report about pediatric and teen mental health. And we know that the AAP, the American Association of Pediatrics, the American Association of Child and Adolescent Psychiatrists, and the Children's Hospital Association issued a very concerning report in October saying that kids are at high risk and are experiencing unprecedented levels of anxiety and depression. So it's not a coincidence. And I think that moving forward, we need to be better at recognizing that health is about more than the absence of COVID-19, and that people face myriad threats to their health and well-being, from depression, diabetes, obesity, substance use disorder, and highly contagious respiratory viruses. That is our job in healthcare, is to think broadly about health.
One of my biggest concerns about this, aside from all of the other things that we've just discussed, is this massive loss of public confidence in medicine, in science, and in the political leadership of this country. We have to get back to science, we have to get back to medicine, and we've got to figure out a way to restore the public's confidence in those who make these type decisions, that they cannot be political. With that, Madam Chairman, I yield back.
I thank the gentleman, and I agree. Chair now recognizes Mr. Ruiz for 5 minutes virtually.
Thank you, Chairwoman. This is a very special day and hearing for me, not only because of the topic, but because a good old friend is part of the hearing witnesses. I texted Dr. Dan Caddlek earlier today, and I said, who would have ever imagined during those long hours of studying at Harvard Medical School for our exams, that one day he would be a witness in the hearing before Congress, and I would be a member of that committee. And we worked tirelessly fighting to reduce disparities and fighting for health equity as medical students, as residents, and now here we are doing the same work. And I'm so proud of the work and his leadership throughout all of this. So thank you, Dr., my good friend Dan Caddlek, for being here. The nation's health system relies on a range of professions and people to support the health of all people in all communities. From the public health infrastructure within federal, state, local, tribal, and territorial health agencies to the networks of nonprofits and private healthcare facilities, it takes every entity working together to prepare for and respond to public health emergencies, in addition to preventing disease and promoting Americans' health every day. Unfortunately, the COVID-19 pandemic has been a stark example of the consequences of failing to support a robust public health infrastructure. According to a Kaiser Health News and Associated Press analysis from August 2020, in the decade prior to the pandemic, at least 38,000 state and local public health agency jobs had been eliminated. 38,000 jobs had been eliminated in public health. And now, 2 years into this pandemic, we're continuing to grapple with the consequences of our weakened public health infrastructure. Dr. Caddlek, has the weakened public health infrastructure impacted your patients and communities across the public health information and education about COVID-19? And would strengthening this infrastructure, especially within the IHS system, help address access and health disparities and inequities Native Americans face? And if so, how?
Thank you, Congressman Ruiz. There is, as we all have seen in the past couple of years, a tremendous disparity, and that's been uncovered by the pandemic and the delivery of healthcare services. And it's no more evident than what we see in Health and Human Services, and especially in providing healthcare to those rural communities, and also those communities with underrepresented individuals who are increased risk for health disparity, whether they exist in rural communities or they are in urban communities in impoverished areas. The placement, as we had spoke about with many of the interviewees and the people on the panel today, is the workforce need. So it's an interesting predicament we are right now, and I really recognize the fact that we have two American Indian individuals on this subcommittee, which is not typical for Congress, but the issue of dealing with what we're going to do with the problem moving forward. And so I think we have multiple lessons to garner information from, but what are we going to do about it in terms of workforce?
I'm glad you said, what do we do moving forward? Because in some of the more underserved parts of my district, community health workers, or the promotores, played a vital role in keeping my constituents safe and healthy. They were the ones educating those communities on how to obtain and use PPE, how to access testing, and the importance of getting vaccinated, and build trust between the community and the healthcare professionals. They became critical liaisons between my constituents and health and community support systems like the county health department, churches, and our healthcare district. This certainly is not the last pandemic that we will face, and there are lessons that we learned through this one that we can carry into our planning for the future. Dr. Caddlek is a provider who cares for a widely underserved population. I know you have seen the unique challenges that those communities face. Do you see an increased role in our use of community health workers, both in future pandemics and in our public health education systems in general?
Community health workers and public health nurses and primary care providers together can provide that role for those areas at most risk. And looking at options for loan repayment, as one of our panelists had mentioned, I know that the loan repayment through the Indian Health Service is not a tax-deferred loan payment. There's a current bill in Congress looking at providing a tax-deferred option for the loan repayment. I was an Indian Health Service recipient of that scholarship, and I'm looking forward to more
Thank you,
progress.
Dan. I got about 10 seconds left. I want to ask Dr. Ranney. You talked about how healthcare delays caused worsening health outcomes. We have lack of access in underserved communities. How has those health delays affected the disparities that we see in underserved populations' health?
Thank you, Representative. It's a joy to see you, and thank you for representing our specialty in Congress. Very briefly, we already had wide disparities according to race and ethnicity in health outcomes. Those have only worsened during COVID, both in terms of COVID outcomes and in terms of access to other preventative care and timely treatment. Our safety net hospitals have been the worst affected by the pandemic, by PPE shortages, and of course by COVID itself.
Thank you so much.
Thank you very much. I yield back.
Gentleman's time's expired. Chair now recognizes Mr. Dunn for 5 minutes.
Thank you very much, Madam Chair and Ranking Member Griffith, for hosting this hearing today to discuss the impacts of COVID-19 on American healthcare. The impacts across all medical specialties are so wide-ranging that it would be literally impossible to adequately address them in a single hearing. It is my hope, however, that this committee will continue this important work. Dr. McBride, I greatly appreciate your remarks on ongoing work to raise awareness of the detrimental effects of masking policies and school closures on our nation's children with no proven benefit. President Biden's COVID response team and public health officials have actually failed our children in this regard. America is behind the curve on in-person schooling and school masking policies, and the most concerning impact that I'm hearing about is a sharp uptick in suicidal ideation among children, as well as record numbers of children presenting to emergency rooms having attempted suicide. This is a government-manufactured tragedy. I'm also learning of developmental and learning delays among children, which is concerning in its own right. This administration's public health policy has been an outright failure and destroyed the credibility of our public health officials, as my colleague, Mr. Palmer, noted. I would like at this point, if I may, to enter into the record an article published last week in the New York Times. The CDC isn't publishing large portions of the COVID data it collects. I submit that for the record, if I may. Do I have consent, Madam Chair? Do I have your consent for put that in the record?
That objection so ordered.
Thanks so very much. To make matters worse, the New York Times has just revealed what many of us had been suspecting, that is that the CDC had been cherry-picking its data and its studies to suit their message as a means to a political end. They were controlling people, not disease, controlling people. Americans can't make good decisions for themselves and their families when they have no trust in the public health institutions. CDC has violated that trust, and this subcommittee needs to hear directly from them on that subject. While the mental health impacts of the pandemic are already apparent, the long-term physical health impacts are only beginning to become apparent. In my specialty, urology, a record number of newly diagnosed prostate cancer cases are presenting as metastatic disease, that is to say, too late to cure. We know early screening saves lives, and I can't stress enough how important it'll be for people to get back to their doctor's office and make up for the missed opportunities of the last 2 years. Dr. McBride, to that end, as you know well, hospitals facing a surge of COVID-19 cases postponed many semi-elective surgeries and medical services. Do you think that the postponements and now rescheduling of those elective and semi-elective procedures could be contributing to the current high case volumes, even as Omicron is subsiding?
Thank you very much for that question. Yes, I think that delaying care for underlying health conditions has caused major problems. Pre-pandemic, we had surging rates of obesity, substance use disorder, and
Lots of things.
Excuse me?
Lots of things. So let me ask you, in your hospital, would you say it's bed capacity or staffing shortages that are most critical to the hospital's capacity to take new patients?
I'm sorry, can you repeat the question?
Shortage of beds or shortage of staff? Which is more critical in your hospital?
So I'm not sure I'm the right person to answer that question because I work mostly in the outpatient setting.
Okay, fair enough. I've been surveying a lot of hospitals in my district, and they all say it's the staffing. I'd also like to ask you this. We know that the public health agencies failed a lot on the messaging, specifically on natural immunity. They've only recently recognized that. Can you tell us what that meant to our COVID response? And tell me also if there's any disease that we vaccinate for after somebody recovers from that disease. So smallpox, yellow fever, diphtheria. Do we come in behind the disease and vaccinate? I can't think of one.
Well, I can think of one off the top of my head, which is the chickenpox virus that lives latent in our system. If we had chickenpox as a child, we boost people later in life to prevent shingles, which is the reactivation of chickenpox.
That's a different virus,
Sure.
vaccine.
Excuse me?
It's a different vaccine.
Yes.
Yeah. So, I mean, you don't reintroduce chickenpox to the...
So let's talk about natural immunity. So I don't love the word natural immunity because
From infection.
But what I would call, there's vaccine-induced immunity and there is infection-acquired immunity. We all ultimately will be exposed.
I see my time is running out. I'm just going to say that when I was in med school, they taught us that mandates undermine public confidence in public health. And it was axiomatic we didn't do that. But I yield back, Madam Chair.
Dr. McBride, do you want to finish your answer on that?
About the
natural immunity versus...
Sure. So there's infection-acquired immunity and there's vaccine-induced immunity. We all ultimately will be tragically exposed to coronavirus, whether we want to or not. Doesn't mean we'll all get infected or get sick. We'd rather be prepared by getting vaccinated when we are ultimately faced with the virus, because the vaccines, as we know, take the claws and the fangs away from the virus and turn it into a more manageable disease. At the same time, it's important to recognize infection-acquired immunity is real, and in some people and populations is more durable and superior to vaccine-induced immunity. It's important we recognize that the human immune system is not a political body, that it has that it's the human immune system, and that we need to recognize people's lived experiences, people who have been exposed and infected, and to weave that into decision-making in the doctor's office as to whether or not to get a third shot, a fourth shot, whatever we end up doing in our public health guidance. And also we need to recognize that should drive public policy when we're thinking about mandates.
Thank you. Thank you so much. Goes back to, as Mr. Palmer said, science. Let's now recognize Ms. Rice for 5 minutes.
Thank you, Madam Chair. The public health and healthcare workforce shortages in the United States obviously predated the pandemic, but as we all know, it has made an already bad situation rise to the level of a crisis situation over the past 2 years. Even before COVID-19, public health departments faced a workforce shortage created by limited resources and an exodus of retiring workers. These existing challenges were further amplified under the strains of the pandemic. But the shortage in health professionals isn't just limited to the public health sector. Estimates by the Health Resources and Services Administration predict that by 2030, the demand for all types of primary care providers, including physicians, nurse practitioners, physician assistants, will exceed supply of these workers by more than 15%. Demand for nursing occupations in long-term care settings is likewise expected to grow 46% by 2030. So it's clear that we need strategies and solutions to address this provider gap. Ms. Austin, can you share more about your experiencing managing Emory Midtown's nursing team through staff shortages during the pandemic, and let us know what your biggest challenge in keeping your shifts actually staffed?
Yes, thank you for the question. We talked earlier about the cost of travel contracts. What we've done here at Emory is that we have invested in contract labor. One, because we know that when nurses have the support that they need, when nursing ratios are adequate and are safe, our patients receive better care. That's a big thing that we stand on here at Emory is quality patient outcomes. We couldn't have done it without contract labor. We want to make sure that, again, our nurses have safe staffing ratios. And even prior to the pandemic, we had what I would consider probably one of the best nursing staffing ratios in the city. And we get that information from nurses who come to us from other hospitals. So I would say that we're typically done a really good job with that. We're ahead of most health systems in that respect. But we're not immune to what's happened during this pandemic where we've seen nurses leave. So we've had to, again, bolster our staffing using contract labor to ensure our patients receive the care and have the outcomes that we want them to.
Thank you. Dr. Riley, you referenced in your testimony the Association of American Medical Colleges. the fact that they found that the strains that COVID-19 placed on the health workforce has been felt most acutely by women physicians and physicians of color. And as you stated, the field of obstetrics and gynecology has been particularly impacted. How have these shortages affected maternity care teams and patients in your practice?
So I think that the concern is that because we work in a team, when we're missing even one or two people, and their expertise, it's really difficult to give patients the experience that they deserve. So we, break our necks to be sure it's safe, but being able to take the time to teach breastfeeding and take the time to, get people ready to go home with this newborn that they don't know what to do with. Those are the things that tend to get lost. And so I think that unfortunately, I suspect that there are patients who will say my experience was not as great as it could have been. And I think that that's really pretty tragic. I do think also, as we think going forward, it's not going to be a quick fix we can't just plug people into the workforce. And so I really think that we need to think way back and start at STEM. We need people who are going to be able to, really work on the science, as people have said multiple times during this conversation. And we need to start that as early as, third grade, fourth grade, whatever it is, and get people excited about science, because we just need so much help.
Well, you make a good point, Doctor, because, if there's one thing that we've seen also, maybe one of the upsides was that there has been this increased interest in people getting involved in the medical field, whether it's from, EMTs to nursing to doctors. And we should do everything we can to enable people to enter those fields, because obviously, as we've all been talking about, we need to increase the pool of this workforce. So thank you all so much for coming testifying today, and I yield back the balance of my time. Thank you, Madam Chair.
Thank the gentlelady. Mr. Joyce, you're now recognized for 5 minutes.
Thank you, Chair Dingell, for yielding, and to Ranking Member Griffith for holding this hearing today. I would also like to thank our distinguished panel of physicians and health providers for not only appearing here today, but for all the work that you've done during this pandemic. Dr. McBride, recently entered into this hearing, a New York Times article reported that the CDC over the last year collected extensive data on vaccine and booster effectiveness, breakthrough infections, and wastewater collection for the presence of virus, but subsequently released very little information of this data. Even what was released included the CDC Morbidity and Mortality Weekly Report, which was published in late January of this year, showed that during the Delta surge, case rates for those with previous infection, what we consider acquired immunity, and no vaccination were substantially lower, almost 4 to 5 times lower than those who were previously vaccinated, 4 to 5 times lower with acquired or natural immunity. And hospitalization rates followed a similar pattern. What is the impact of the CDC withholding data or delaying the release of that data for you as a healthcare professional on the front line, treating those with COVID-19? Does this withholding data fracture your relationship to utilize CDC information when you're one-on-one with the patient?
Thank you for that question. Trust is the glue in patient care and in public health. And I do worry that we have seen an erosion of trust in doctors and in public health institutions. We need our institutions to succeed. I want the CDC to succeed. We need to have broad public health advice. We also need clear communication of truthful, real-time data and information. We need to have, as Dr. Ranney touched on, we need to understand who's in the hospital. Is it an incidental COVID infection, or is it someone who is in the hospital for COVID-19? Is that person, we need to know in terms of racial and ethnicity data. We need to know, do they have underlying conditions? We have so much work to do to have the public understand and trust what the CDC is telling us. One of the parts of my job that has been very, very challenging during the pandemic is helping people make sense of the news and the changing guidance. You know, people don't have the luxury of paying attention to COVID like I have every single day for the last 2 years, and so they're calling me with just everyday decisions. And I think one of the challenges is that even people who are paying attention have a hard time making sense of the guidance, and there has been an erosion of trust because they see the New York Times article, for example, last weekend, talking about withholding of information. Again, I do not ascribe malintent or ill intent. I simply think we need much more transparency and trust and communication of facts to the general public. I think another thing is for people to trust the CDC needs to trust people. It needs to trust people that they can handle murky and muddy information. When I have a patient who has a diagnosis, but I'm not yet sure what the trajectory is, it doesn't help my patient for me to withhold information or to not tell them the full truth. I want to give them hope when it's rooted in the facts and the science, but I also want to be honest and real with them about what's going on. Same goes for the public. People are smarter than we give them credit for. The public is paying attention to a lot of the data that's coming out. And I think if the CDC could more transparently communicate facts and data in real time, then we as primary care doctors can act more as the lieutenants for the CDC and transmit that information to our patients for their everyday lives. Should I go to school? Should I go to work? Which vaccine? How many booster shots do I need?
Does my time is limited, but does that lack of transparency and transfer of information, which you just discussed, does that make your job more difficult?
Absolutely.
As a Johns Hopkins trained physician, someone who is used to dealing with data, used to dealing with this every day of how you practice, does that lack of transparency from the CDC make your job as a physician more difficult?
It absolutely does, and one of the reasons why I've cut my practice in half in the pandemic and am donating 50% of my time doing advocacy work and pro bono work is that I'm trying to help people stripped of politics, stripped of ideology, no financial incentive. I'm reaching now almost 20,000 people with a weekly newsletter to dispense nuanced, contextualized information to a wide audience. I'm reaching people in rural America. I'm reaching people in urban areas who don't have access to primary care doctors. It's hard when the CDC is putting the burden on the general public, and when we don't have access, 80 million Americans, as I said earlier, don't have access to a primary care doctor. To translate the information, sometimes confusing and sometimes not the full picture, into everyday decision making. And so again, we need trust, transparency first and foremost. We need primary care doctors out there for people to have access to information and we need primary care doctors to be able to trust the CDC. Again, I believe in the CDC. I trust the CDC in many ways, but we need to do better.
The gentleman's time's expired. Thank you.
Thank you, and I
Chair
yield.
now recognizes Ms. Schreier for 5 minutes.
Thank you very much, Madam Chair. This has been quite 2 years, and we have learned a ton, and a lot of those topics have been discussed already today. I think that there are questions that are still going to come at us and that may hit us very hard. My question is going to be directed at Dr. Riley, so I'll just give that heads up. I'm a pediatrician, 20 years in practice. I've experienced vaccine hesitancy. There's about 1% of the parents that I would see who would flat out say, no, not immunizing, no way, no how. Probably around 10%, 15%. Just questions. They just very legitimate questions. Just had to meet them where they are, answer some questions, make them feel reassured, and then we moved on and got everybody vaccinated. I have just been blown away by how politicized this has become, by the extreme misinformation out there and vaccine. It's not just hesitancy. It's like a rabid sense that is anti-vaccine. The question I think we may be headed for now is, what will this now do to routine childhood vaccinations? That it's not just going to be a question of whether children in school should be required to have a COVID vaccine. It is, I'm wondering, perhaps going to be a question of re-examining every routine childhood vaccine, measles, mumps, chickenpox, you name it, and questioning that. And so, Dr. Riley, I was just wondering if you could comment on any concerns you might have there, or what you thought might be coming our way.
I certainly agree with your thought that vaccine hesitancy is, truly a problem. I think the WHO just recently, named vaccine hesitancy as a global health issue to really be grappled with. And I think that we have to recognize that as people lose confidence in science, which is unfortunate, and as our inability to communicate in all the different ways that we need to, that just fuels the vaccine hesitancy. I think that we have to get back to the basics, understand, the diseases that we're trying to prevent, let the public understand the diseases and how devastating they can be, and then, re-educate on the benefits of vaccines, not in addition to the safety, but also the benefits to prevent disease. And I think that that's, sort of where we're going to need to go. But I share your concern as I try and, explain to pregnant women every day that this is the COVID vaccine is something that we feel will decrease the likelihood that they themselves will be ill, and that there's evidence now that there's protection for their babies.
Thank you. I share those concerns. In fact, I'm even a little bit more concerned now because even seeing how many people have died in this country, how many people are in the hospital, the vast difference between vaccinated people who are safe from being in the hospital or dying and those not. Even with that data, there's still extreme hesitancy. And so I wonder if conversations about measles and how devastating that can be will even carry. Speaking of lack of trust, just a quick question for Dr. Ranney. Public health. There's tremendous need across the board. We don't have a public health infrastructure, and then distrust grew in our public health system. Do you think that if we had a baseline public health infrastructure where in routine cases they would be doing well baby visits at homes and helping with mental health and substance abuse disorders, if we had that infrastructure already in place, do you think we would have more success rolling out a big public health campaign come any future pandemic?
Thank you, Representative. Absolutely. Our investing today adequately in our public health infrastructure is critical for us dealing with future surges of COVID and whatever comes next. Community health workers and peer specialists are important. Disciplining physicians who are active purveyors of disinformation is critically important. And are correctly interpreting and sharing those interpretations of data with our patients is important. And I actually want to take a moment to correct some of the prior information that has been shared. There actually was not a dramatic increase in pediatric suicides during lockdowns. In fact, pediatric suicides dropped dramatically during lockdowns. And we've seen a small increase in adolescent girls' emergency department visits, most significantly over the last couple of months. So I just want to correct the record on that part. But overall, investing in public health infrastructure, ensuring that they have adequate workforce, adequate tools, adequate ability to get data and then share it nationally, which will speed up the sharing of data by the CDC if they get good data from local departments, is absolutely critical to our meeting the challenges of the future head on.
Thank you very much. Thank you for setting the record straight. I yield back.
Thank you so much. Chair now recognizes Ms. Trahan for 5 minutes.
Well, thank you, Chairwoman DeGette and Ranking Member Upton for holding this important hearing. As many of my colleagues have mentioned today, the COVID-19 pandemic brought healthcare workforce issues to the forefront as it exposed gaps and weaknesses in our nation's preparedness for public health emergencies. And these workforce issues are present across healthcare workforces and have highlighted the need for public health, behavioral health, EMS, primary care, and long-term care professionals. The effects of these shortages are especially felt in underserved communities, which have historically experienced diminished access to healthcare services. Indeed, nearly half of the counties in Massachusetts have shortages of infectious disease physicians, and our westernmost county has 0. That's why I introduced the Bolstering Infectious Outbreaks Preparedness Workforce Act with Congressman McKinley, which will offer student loan repayment as a major new incentive to recruit more physicians, nurses, and other healthcare professionals to work in infectious diseases and biopreparedness in communities with the greatest need. So Dr. Ranney, why is access to loan forgiveness, especially for medical specialties with lower average annual salaries like ID physicians, important in building up and retaining a robust and diverse healthcare workforce?
Thank you very much for that question. So the average physician graduates with more than $200,000 of debt. They go through residency where their debt continues to grow. And then that can dissuade folks from taking on some of the lower paid professions. Many folks that do go into primary care actually choose to not take insurance and to take direct concierge care payments instead in order to increase their income. I myself was the benefit of the loan repayment program in order to pay off my medical school loans. I know that Dr. Caddlek was as well. It's critical in terms of getting physicians and other healthcare professionals to be able to work on the front lines in underserved communities, to be able to spend time doing research and to do other critically important public health functions, and to not take those higher remunerating jobs, to not have to go to areas that pay better. I'll also say that loan repayment would make a big difference for those that have been on the front line for the last couple of years as a small token of gratitude to help retain frontline providers who have been there throughout the pandemic. Having a loan repayment program such as Congresswoman Maloney's would be helpful for those who have served throughout the pandemic.
Absolutely. And I thank you for flagging Chairwoman Maloney's bill because I couldn't agree more. I'm going to switch gears because the president mentioned last night in his State of the Union address the importance of Congress conquering other public health crises, such as rising substance use disorder rates that require specialized healthcare professionals. And I'd like to just ask you one more question, Dr. Ranney. As you noted, the importance of American Rescue Plan workforce investments, including for substance use disorder treatment and recovery programs. I was encouraged to see that Brown University's Warren Alpert Medical School class of 2020 graduates were the first in the nation to graduate with training that allows them to prescribe medications to treat opioid use disorder in any U.S. state. So as a trained emergency physician, you interact with patients seeking treatment for a range of physical and mental health issues and often have opportunities to provide effective interventions for individuals with an opioid or other substance use disorder. In your experience, do you agree that more patients with OUD could be helped if comprehensive training on how to identify, treat, and manage patients with a substance use disorder was the standard?
100% I agree. In my emergency department, thanks to the leadership of our former director of health, Dr. Alexander Scott, as well as our former governor, now Secretary of Commerce Raimondo, we actually have standard screening. We have standard protocols for every patient that comes in with opioid use disorder. We prescribe Suboxone at the bedside during an emergency department visit for folks who've overdosed on opioids. That's been shown over and over again by my fellow emergency physicians, as well as addiction medicine specialists, to be the best way to help prevent overdose deaths. Surrounding that with a suite of peer recovery supports is also critical, whether in person or remote. This is one of the most important things that we can do to help folks who are subject to opioid use disorder. And I will strongly urge that we actually get rid of the X waiver requirement, which is a huge barrier to prescribing a medication that is no more dangerous and perhaps more helpful than many of the medications that we prescribe every day for many other disorders.
Well, thank you. I appreciate both of those answers. And to all the other witnesses, thank you for your testimony today. I yield back. Thank you, Madam Chair.
I thank the gentleman. Chair now recognizes Mr. O'Halloran for 5 minutes.
Thank you, Madam Chair and Ranking Member, for holding this meeting. Thank you to the panelists for their presentations today. The issues that we have heard from today's witnesses are not new. The pandemic has strained our health systems and exposed our doctors, nurses, and frontline workers to overwhelming conditions and a constant struggle to treat patients and save lives. I was happy to spend the last 2 weeks touring my district and talking to healthcare providers and administrators. These are rural and tribal providers, and they are struggling. Some of these struggles are not new. Payment models continue to discriminate against rural providers, and healthcare systems continue to incentivize doctors and providers to settle in urban and suburban areas and practice medicine in well-resourced settings. But what is new are incredible staffing challenges. Hospitals, community health centers, our doctors' offices, paramedics, EMTs, and ambulatory services, among others, are all suffering from the same staffing issues, and it is harming access to care in rural and tribal areas. This is an area that this committee needs to be focused on, and I look forward to working with anyone who is interested in actually addressing the issues that rural and tribal communities are facing. Just as a side issue, you know, a lot of people say, well, why don't they just move into urban areas? Well, we need them out in rural areas for producing the food, bringing water in, making sure our transportation systems work, on and on and on. This is a combination that is needed critically in our future. So Dr. Caddlek, thank you for joining us today. Your testimony highlights this long-standing lack of investment in Indian Health Services facilities. Can you elaborate on some of the challenges the Indian Health Council faced in providing quality medical services within your community before the pandemic?
Thank you for the question. Just a couple comments regarding the workforce that currently exists now. So I'm one of only 2 pediatricians in the area, probably surrounding 50 miles radius from our site. So that poses a challenge to provide that pediatric care. But also with the same concern for the demographic, the need to have kids enter STEM programs such as the Native American Research Centers for Health, which is a NIH funded program to retain and recruit Native Americans to go into medical school and or research, is an important program that actually highlights your concerns and the needs for promoting recruitment and retention for this workforce. And I'd also like to comment on the fact that my son is actually one of, actually the only MD PhD who will be at University of California, San Diego, providing or finishing up his studies there for over the last 4 years. But he will be the only Native American from this area to accomplish that feat. So I think just examples of those wide disparities show a need to have a continued workforce and some of the challenges that tribes and the rural areas as a whole across the country are facing.
Thank you, doctors. And this is another question for you. Since my time in Congress, I have focused on addressing the long-standing failures of the federal government to provide support to tribal communities and, for that matter, rural communities throughout our country. However, since the pandemic, Congress has taken several actions to support tribal communities, including increasing funding through the CARES Act, the American Rescue Plan, and the Bipartisan Infrastructure Investment and Jobs Act. Which programs have been most effective throughout the pandemic, and should be reworked to provide additional support to tribal healthcare, and if you can comment also to rural healthcare?
Yeah, thank you. The funds that have been provided through the CARES Act and through several different funding mechanisms to support the tribal missions in the area have been phenomenal. And without those funds, we would not have been providing the care that we've done so with testing, tracing, treatment for those individuals afflicted with COVID, and providing the supportive care for the preventive healthcare measures that we've had to catch up on. It's said that pediatrics are almost a year and a half back in terms of preventive health exams. So I think looking at Indian Health Service funding and other public health service programs, since the budgets have been relatively flat over the last 10 years, is an important first step.
Well, and thank you, Doctor. Thank you, Madam Chair, and I yield.
I thank the gentleman. We have several members of the full committee who have asked to waive on, and we're always pleased to accommodate them. So first, I will recognize Mr. Carter for 5 minutes.
Thank you, Madam Chair, and thank all of you for participating in this. It's extremely important. I want to ask kind of a general question. I'll start with you, Dr. Ranney. What data do you think the CDC should be collecting at this time that it hasn't collected?
Thank you for that question. The big challenge that the CDC faces is that there is very little mandated data from local or state health departments that is required to be reported to the CDC. There's also a lack of standardization of data, which means that when the CDC gets it, they have to spend a lot of time cleaning and verifying it, which then delays release of the data to the public. And there's simply an absence of much data, such as others have outlined, age, race and ethnicity, income level, et cetera, of cases and hospitalizations. There's a lack of data around adequate staffed beds. HHS reports hospital beds and hospital capacity, period, but doesn't take account for staffing shortages. The wastewater data is a great thing that's going to be really important for us for predicting future surges. I could go on. The best analogy that I can make is I think back to when we fought the epidemic of car crash deaths back in the 70s. We developed NHTSA, and we developed multiple well-funded data initiatives within NHTSA, such as the Fatality Accident Reporting System, the EMS information systems. Those are critical ways that we can monitor in real time new reasons for increasing car crashes and car crash deaths, and then change things accordingly. We need the same type of system in place for COVID data to allow us to have early warnings and to respond in kind.
Well, thank you. Thank you for that. Dr. Riley, I'll ask you the same thing. What data should the CDC be collecting at this time that you don't think that they're collecting?
So I mean, I think I would just add on to that one of the major issues that doesn't ever come up is whether or not someone's pregnant or lactating. And so that field alone would allow us to understand, what's happening to that particular patient population. And as I said in my testimony earlier, I think that we need to understand two things. One is, what's the impact of COVID infection on pregnancy and lactating women? And then what is the effect of, or the effects of vaccination on that same population? But without asking those questions, we're sort of left not knowing.
Hey, great responses. Thank both of you. Dr. McBride, I'll go to you. Do you think there should be a wider variety, if you will, of voices that at the COVID-19 response itself? Are we including enough different people and enough different and a variety of people, of professionals?
Thank you for that question. I think the more voices, the more diverse array of experiences and areas of expertise, the better. Personally, I wish that there were more mental health experts.
Exactly.
In the COVID-19, because this is a collective trauma. This is like no other experience in at least my lifetime, but it's a collective trauma that really warrants careful attention to individual and population mental health. But yes, absolutely, we need all sorts of races, ethnicities, income levels, areas of expertise,
Good.
all of it.
Thank you, thank you. Ms. Austin, I wanted to ask you very quickly, do you feel like the clarity that you got from CDC for your nursing staff on when to wear PPE and what kind of PPE, do you think that was sufficient?
I think early on we had a great deal of trust in the information that we were receiving from the CDC. I think the thing that caused a little bit of concern was when some of those things changed. I've heard from many of the nurses on the front lines is there concerns about the changing mandates, the changing information. So I would just say that yes, there was concern about the information that changed. But overall, I would say that I respect the CDC's position and has followed their guidance throughout this pandemic.
Good. And Dr. Caddlek, I guess you're the only one I haven't asked a question. The same question there. The consistency of the CDC and the information you were getting?
Just to echo Ms. Austin's comment, yeah, the PPE that we've been trained for many years in its use and multiple different situations, other than just COVID, I think was a usual practice that we had instituted. However, the effectiveness of different masks, whether they be 2 layers, cloth, N95s, was somewhat disparate as we move forward in the pandemic, but still looking forward to additional support and improved guidance as we round out the pandemic, and looking forward to the next.
My time has expired. Thank you, Madam Chair.
I thank the gentleman. Chair now recognizes Mr. Sarbanes for 5 minutes.
Thank you very much, Madam Chair, and thank you for allowing me to wave onto this hearing today. I appreciate it very much. Obviously, the focus here has largely been on workforce shortages, particularly aggravated or exacerbated by the pandemic when we look at the healthcare workforce. But we know these shortages have been accumulating. It's I guess, a strange turn of phrase, shortages accumulating, but that's what's been happening for years now, and we're just looking at new and extra dimensions of that challenge. I've been focused on this for a long time, was able to work to get a provision into the Affordable Care Act that would create a national healthcare workforce commission to kind of systematically look at and assess what the shortages are and put forward recommendations, policy recommendations on how to address them. We're going to continue to try to bring that focus to bear. But we also have to get creative, I think, and innovative about how to meet those shortages, whether it's nurses or physicians, other caregivers in the continuum of care. And Dr. Ranney, I apologize if I'm not pronouncing your name correctly, but I'd be interested in getting your perspective. I have a bill that I'm reintroducing called the Primary Care Physician Reentry Act. It would direct the Department of Health and Human Services to establish a demonstration program that could facilitate physician reentry into primary care clinical practice after an absence from their practice for one reason or another, after retirement. So trying to create an incentive, an expedited process of bringing these physicians back. Do you think that that's a good idea? Could that help us? Do you think that it would be appealing to retired physicians? Do you think it could help us address this workforce shortage? If you could speak to that, I appreciate it.
Thank you. I'm not familiar with your bill, but look forward to learning about it. I will also say that Dr. McBride is the primary care doc, not me, so I will let her talk about what will get folks into primary care. But I do think that providing avenues, on-ramps to get physicians who have left bedside care back comfortable with the current clinical care environment, with current data around medical care, and getting them back into the clinical sphere is certainly something that would be helpful. Whether it's about retired physicians or others who have left bedside care for a variety of other reasons, having a way to reacclimate, to build up our clinical skills and get back into bedside care is a terrific idea.
Thank you, Dr. McBride. If you could give me a quick thumbs up or thumbs down on that as a possible benefit in terms of getting more physicians into the to address this shortage.
Whatever we can do to get more people into primary care, and not just to get more people in primary care, but to incentivize them to go into primary care instead of subspecialty medicine, for example. Those of us in primary care went into this field to be able to have time with patients, to establish a relationship so they can talk to you about their depression, their anxiety, and their dementia and their diabetes and their myriad health issues. My patient who's 82, I saw earlier this week, he's on 15 medications. He has a new heart valve. He has atrial fibrillation. He has hypertension. He has diabetes. And he's newly lost his wife. If I have 5 minutes to talk to the patient, I really cannot do my job. I cannot do what needs to be done. So we need to make sure that we are not only incentivizing doctors out of medical school to go into primary care, we need to change the system so that time with a trusted guide is the commodity, instead of treating primary care as just sort of a referral mill where the rapport and the relationship isn't the commodity. The commodity needs to be the trust, the rapport, and the relationship. There's a lot we can do when we sit down with our patients and talk to them, look them in the eye, and help them kind of meet their broad human needs by understanding who they are as a person and what their specific vulnerabilities are and how to protect them from the myriad threats that people face, whether it's COVID-19 or loss or other health harms.
Appreciate that, and I like that idea of the commodity of trust and how we can invest in it and make sure that we reimburse for it in a way that creates the right incentives. Dr. Ranney, I've just got a couple of seconds left here. Why shouldn't there be a school-based health center in every school in America to address not just physical health needs on the part of our students, but the increasing mental health needs that they need, fully staffed with counselors, with mental health professionals, with social workers, et cetera? If you could speak to that, briefly, I'd appreciate it.
I'll say that, heck, right now, I would just take a school nurse in every school in America. That in and of itself would be tremendous. School-based health centers are great both for getting kids and families care, and they can be augmented with telehealth or with digital care. I will also add that in addition to getting physicians in the workforce, we also need all the staff around us. We are a team. It's not just a physician, it's also nurses, medical assistant, home health aides, and more.
Thank you very much, Madam Chair. Thank you.
I thank the gentleman. But I got to tell you, Mr. Griffith and I both want to thank all of the witnesses for coming today. You were a wonderful panel and a wonderful team who gave us a lot of great information, and we will use it going forward. I want to remind members that pursuant to committee rules, that they have 10 business days to submit additional questions for the record to be answered by witnesses that appear in front of the subcommittee. And I want to ask the witnesses, if you do get these questions, if you can respond promptly to any of them. And with that, the subcommittee is adjourned.